Listen. Good morning. We're going to be starting in just a moment. I'm going to give everybody time to filter in, and then we will be getting started in a moment. Thank you for coming. Hi, everyone. We're just taking a moment to let everybody get in the webinar, and we'll get started in just a second. Thank you. All right. It looks like everybody entering has kind of like filtered out to about a few people. We got a couple more coming in. So I'm going to give it one more minute and then I will go ahead and get started. Thank you. All right, I'm going to go ahead and get started with the introductions. Welcome and thank you so much for joining us for the second ACC Connections Patient Conference. My name is Amanda Fleet and I have been a caregiver for my mother who has had adrenocortical carcinoma for 10 years. We've been very fortunate to have been able to get her treatment from experts from very early on. And today we're hoping that by gathering all of these experts together in one place that we can share information that will help others see experts sooner, possibly improve treatment options and quality of life, and know the questions to ask their doctors and their care team. So we have an amazing lineup of speakers today, but before we get started, I wanted to go over a couple of things. Please remember that the information presented today is for educational purposes only. Please consult your care team regarding decisions for your personal situation. Another thing is feel free to add questions to the Q&A. We will address them as time and availability allows. We have been collecting questions from patients and caregivers over the past few weeks, so we do have some collected already, but if you have more, feel free to add to the Q&A. Another thing is that we will be recording this conference and be posting it in the coming weeks for you to share with your care team, family, and friends. Again, thank you so much for coming, and thank you to our speakers, the ACC Connections team, and Dr. Del Rivera for all the hard work it took to put this together. And I would like to introduce our moderator and our chairperson for today, Dr. Hajira Del Rivero. Dr. Del Rivero is board certified in internal medicine, endocrinology, diabetes and metabolism, and medical oncology. She's a physician scientist in the developmental therapeutics branch of the National Cancer Institute, the principal investigator of the natural history study for neuroendocrine neoplasm and adrenocortical cancer, and national PI of NCI's National Clinical Trials Network with the Alliance for Clinical Trials in Oncology. She's also just an amazing doctor, and I have to say that I greatly appreciate her and the work she's done. She's definitely helped my mom a lot. So thank you, Dr. Del Rivero.
Great. Thank you so much, Mrs. Fleet, for the kind introduction. And just wanted to let you know that I'm very grateful and honored to be with you all today, and our patients and caregivers who are participating today. Thank you so much for being the constant, reminded of, the work that we do and our inspiration. You're truly our inspiration. And thank you so much for all of the efforts that you do as well. It is my pleasure to introduce the first speaker of today. I would like to introduce Dr. Alfredo Berruti. He is a medical oncologist and professor of medicine at University of Brescia, Italy. I have to say that I'm so grateful, Dr. Berruti, for your participation today. Dr. Berruti has led many studies of how we treat ACC today, and all of the studies about chemotherapy for ACC, and how the options that we have. We have to say, I have to thank Dr. Berruti for all of the efforts, and so many today, but it is my pleasure to introduce Dr. Berruti today. So with that, the floor is yours.
Thank you, Dr. Rivero, for the beautiful and undeserved presentation. I would like to thank the organizers for inviting me. I greatly appreciate this invitation. Patient association play an important role for ACC patients, in particular because we are dealing with extremely rare disease. So these are my disclosure. Well, adrenal gland is a complex gland. I always say there are two glands in one. The central portion is named medulla and is producing catecholamines, adrenaline, noradrenaline, while the peripheral part named adrenal cortex is producing many hormones such as cortisol, aldosterone, androgens, which play many important physiological, which have many important physiological function. These glands rarely undergo malignant transformation, and tumor arising from the medulla are named pheochromocytoma. But we are talking about tumor arising from the adrenal cortex, the adrenocortical carcinoma, which incidence is extremely rare. It affects between 0.7 to 2 new cases per million population per year in Western countries. Female are more frequently affected than male, and in adult population, the peak of maximum incidence is between the 4th and 5th decades. Of course, rarely, extremely rarely, this disease may affect also children. What is the clinical presentation of ACC? There is an increasing presentation of asymptomatic patient. In this case, disease is discovered incidentally when the patients perform imaging for any other need. In 60% of cases, the disease is producing hormones, and therefore the hormone excess address the diagnosis. Less frequently, the patient complain with symptoms related to the growing mass, abdominal growing mass, and sometimes the presentation is characterized by fever, anemia, pain, weight loss, and anorexia. When patients complain these symptoms, often it has a metastatic disease. Well, this is a recent paper we have published together with a group of Massimo Terzolo, and showing that the distribution of the different kind of presentation of ACC, and as you can see, about 40% of patients have the disease incidentally discovered, and 44% of patients have disease with hormone associated with hormone excess. And this is the typical examples of incidentally discovered disease, and you can see in here, this is a small lesion, non-secreted small lesion, and these patients is addressed to follow up. And this is another kind of adrenal mass, which is more extensive, and the suspicion of malignancy is high in this mass, and therefore these patients should be addressed with the diagnostic and therapeutic procedure. When these are the landscape of hormone excess, the most patients with hormone excess have Cushing syndrome, which is characterized by the several clinical manifestations as listed here. Less frequently, the disease onset is characterized by virilization. So this is another important scenario. Rarely, hormone secreting tumors are characterized by hyperaldosteronism, feminization, and so on. And not rarely, this disease is presenting with multiple hormone production, mainly Cushing syndrome associated with virilization. Well, when adrenal mass as a strong suspicion of to be malignant, then a diagnostic workup should be performed, and we don't forget to perform a hormone workup with the evaluation of all hormones that are produced by both adrenal cortex and the medulla, associated with imaging such as CT or MRI when FDG PET when indicated, with the aim to evaluate the disease stand in the body. When the scenario is clear, the therapy is decided not by a single physician, but by a multidisciplinary team. And the Brescia multidisciplinary team is composed by surgeons, endocrinologists, oncologists, pathologists, radiologists, and nuclear medicine physicians. All these people make the decision in all individual patients. This is really very important. And we know that due to the extreme rarity of the disease, only 60% of patients in our series have been diagnosed with early stage, and so potentially amenable to radical surgery. And the remaining 40% were metastatic ab initio, and therefore they were eligible to systemic therapy. So in patients with early stage disease, of course, surgery is the mainstay of therapy, but the multidisciplinary team should decide what kind of treatment should be best performed considering laparoscopic adrenalectomy or open allelolectomy, and therefore an individual decision should be made. Of course, when surgery is usually performed in patients with early stage of disease, while in patients with advanced disease, systemic therapy are preferred, are the best option, are the reference treatment. However, in individual patients, the multidisciplinary team should decide to administer systemic therapy upfront in order to obtain a tumor shrinkage, a tumor volume, downstaging, making this surgery easier. And this is what we did in these patients bearing such a huge disease, as you can see here. After a radical operation, the multidisciplinary team should predict the future for the patients, and the goal is to identify those patients with high risk of relapse, in whom adjuvant mitoten therapy is recommended, and discriminate them from low risk patients with disease relapse, in whom follow-up is the preferred option. As you know, there are people devoted to predict the future, but we are scientists. We have to use evidence-based medicine, and what we usually do is put together the pieces of the puzzle, take into account that we have several prognostic parameters such as disease stage, radical surgery, proliferation activity, cortical hypersecretion. In addition, a GRAS score has been introduced, which include also age and symptoms associated with the disease. Putting together all these characteristics, these features, we can predict the prognosis of each patient, of course, with some uncertainties, but this is the best way we have. And to decide whether the patient should be addressed to adjuvant therapy or not. When we are dealing with patients with metastatic disease, the multidisciplinary team should decide to address these patients to mitoten monotherapies in association to local regional therapies, or in case of low tumor burden and tumor depicting a radial indocent disease curves, or when we are dealing with high tumor burden or tumors with rapidly progressing ADP, the association of etoposide, doxorubicin, and cisplatin as in associated with mitoten should be the standard therapy to be administered. So, in conclusion, as I mentioned in this brief presentation, the management of patients with adrenocortical carcinoma is a difficult and challenging task. We have few therapeutic options, but I would like to underline that are efficacious in many patients and very efficacious in a proportion of patients. And therefore, they should be used in the best possible way by the experienced physician. The most effective individual strategies can be achieved through a multidisciplinary approach, and it should be underlined that for any information or concern, please ask your doctor. I would like to underline that Dr. Google has never been graduated from any university in the world. I would like to thank you for your attention, and this year my team working in rare tumor. Thank you so much.
Thank you so much, Dr. Baroudi, for an overview of adrenocortical carcinoma. And just for the people who is attending this meeting, please feel free to ask any questions. There is a chat or in order for you to ask any questions. And with that, there is a few questions I would like to ask you, Dr. Baroudi. And one of the questions is about how we follow patients over time, or what are the best diagnostic tool for continued monitoring? And with that, could you please explain to us and our patients and caregivers to describe what is the best diagnostic tool for ongoing monitoring a patient with ACC? Maybe you could discuss for patients after the tumors were resected when we don't have any evidence of tumors, and for those that have metastatic disease. And if and also about PET scan too. If you feel that PET scan is also a good tool that we can use for diagnosis as well as monitoring.
Well, thank you for the question. When we are dealing with the patients radical operated, of course, follow-up should be performed and following the international guidelines. The standard, the approach for follow-up is CT scan, and CT scan is usually the reference imaging techniques that should be performed at the specific timing. Of course, PET scan could be performed, but in selected cases when CT scan raise any doubt, some doubt with respect to possible recurrent disease, not clearly evaluate assessed by CT scan, but not in our experience. CT scan is not to be considered as the referent imaging in the follow-up of patient radically operate. Of course, don't forget to associate the imaging techniques with hormone evaluation, particularly if the patient had a diagnosis hormone secreting tumors. In these patients, follow-up which include also hormones evaluation is really important in order to early detect disease recurrence. When we are dealing with patients who have a metastatic disease and was treated with systemic therapy, then again CT scan still is the reference imaging techniques. PET scan could be useful in cases in which we have to better evaluate the disease response, because of course if we are facing with tumor shrinkage, which is also associated with a reduction in PET FDG, then the information we have is okay, the disease really have a good response, and these are good news for the patients, and may be useful for making treatment choice. Address the patients to surgery removal of residual disease.
Great, thank you so much. And another question that has been asked by our patients and caregivers is about ivermectin. Are you familiar with ivermectin? It seems that there has been a study. And what are your thoughts about ACC?
Well, I don't have any experience with this particular drug. I have treated some patients followed by in my institution decide to receive to take niclosamide. That is another anti-parasitic drug. So generally speaking, anti-parasitic drug could be potentially used in the management of cancer patients, but of course, as far as I know, we only have anecdotal cases, and therefore we need to know more before recommending this drug.
Great. Thank you. Thank you. Yes, and for our patients and caregivers, ivermectin is a drug that is used for parasites. But as Dr. Baroudi said, we have a study that we understand what is efficacy in ACC, is not something that we routinely recommend, if Dr. Barudi agree. Now, I have another question here, and that's about if ketogenic diet is safe while a patient is on mitotane or on chemotherapy with EDP, etoposide, doxorubicin, and either platinum or carboplatin or cisplatin.
Yeah, I don't have a personal experience regarding the management of patients during chemotherapy of mitoten who is on ketogenic diet. Maybe some patient could not tell me that what kind of diet he is on. I don't think there is a contraindication. There are data in breast cancer patients receiving chemotherapy showing that this diet is safe. I just only consider that we have to be careful when the patient is on this diet, if they are suffering from nausea and vomiting in the area. In case of nausea and vomiting, probably the ketogenic diet could increase could worsen these symptoms. Maybe this is an hypothesis. And of course, in case of severe diarrhea, the diet is important, and it is composed by potatoes and rice, and these are, as far as I know, food that are contraindicated in ketogen. Probably an intermittent ketogenic diet, if the patients like to be on this kind of diet, could be appropriate when this patient is on chemotherapy.
Okay, great. Now I'm going to ask another questions, and also there is a question as well in the chat. Thank you so much for those who are placing questions in the chat. But one thing is about what are your recommendations about sequencing of systemic therapies in ACC, like for example, temozolomide and or sunitinib. They also ask in the chat about cabozantinib, and what is your experience about that, and if you know the efficacy as well.
Okay, the question is when we adopt chemotherapy or molecular target therapy. Well, generally speaking, it depends of aggressiveness of the tumor when we are dealing with the patients whose disease is rapidly proliferation. Then in theory, chemotherapy could be have the greater chance to obtain tumor shrinkage and to be effective with respect to at least some target therapy, such as sunitinib. I have to admit that cabozantinib, at least also in my experience, is the most promising molecular target agent, and it is the preferred target therapy we are using. So I think the cabozantinib should be better explored in this disease because the initial results are promising. So and cabozantinib should be also indicated when the disease is more rapidly proliferating. Therefore, temozolomide could be an option, target therapy another option, and with respect to sunitinib and cabozantinib, I personally prefer cabozantinib.
Okay, great. Thank you so much. There is a couple of questions about mitotane. So one of the question is, how long is it safe to be on mitotane? And there's another question by Ms. Catherine Lamy, and it's about the levels. I mean, we're going to talk about it throughout the day, but maybe Dr. Barudi, if you could give us also a thought about having the levels of 14 therapeutic levels. It seems that there is a study that they just came, but just to let you know, Ms. Lamy, we're going to discuss more about in detail, but maybe Dr. Baroudi could give us his thought about the importance of the therapeutic levels of mitotane and how long is safe to be on mitotane.
Yeah, mitotane is safe for a long time period. We are sharing with Massimo Terzolo, a patient from Naples who had received mitotane for 18 years. So the clear demonstration that mitotane should be tolerated for a long time. Of course, the duration of therapy should be carefully evaluated by the multidisciplinary team, and a careful evaluation of cost benefit should be considered, because mitotane is well tolerated in a proportion of patients, but not so well tolerated by other patients. So about the duration, the tolerability should be clearly taken into account. But I have experience that mitotane should be safe for even if administered for years, and this is a good information, a good news for the patient. With respect to the mitotane levels, of course, current guidelines and published papers, particularly in the past, recommended to maintain over time a concentration that is between 14 milligram per liter and 20 milligram per liter, the so-called therapeutic range. This assumption has been recently questioned when, in my opinion, what we have to do is to administer to each patient the best tolerated dosage. In other words, if the patient don't tolerate too much the drug and don't attain the so-called therapeutic levels due to intolerance, it doesn't matter. The importance of mitotane therapy is to administer the drug for a long time period, and therefore we have to tolerate to make the tolerability of patients, and therefore we have to the patient should take the dosage of mitotane.
Yeah, great. Thank you so much, Dr. Baroudi. One other question is about if somebody develop gynecomastia because of mitotane, and gynecomastia is growth of breast, would you recommend a surgery in those situations? If there is any medicine that you would recommend to minimize that?
Yeah, the gynecomastia is an unpleasant side effect for men, and in some cases it is a big problem. So it should be managed. My personal recommendation is to take care on concomitant hypogonadism, and therefore perform testosterone supplementation in case of hypogonadism. And we have some positive result with concomitant administration of tamoxifen in order to limit the estrogen mimetic effect of mitotane, which is responsible of gynecomastia, but not a proportion of patients respond to tamoxifen, not all. In case in which gynecomastia is really a problem, and the patient should receive mitotane for a long time period, then surgery could be an option, of course.
Great, thank you so much. There is a question from Ms. Lisa Yand, and her question is, how does someone find an ACC expert?
Of course, in USA, you are lucky because you have a patient association. In Italy, we don't have a patient association. I think patient association could play an important role in addressing the patient to the right physician. There are few in the world because the disease is extremely rare. But it's very important that the patient should be followed expert physicians.
Great. Thank you so much. One other question was that while taking mitotane, can those levels of mitotane be transferred to next person, like through different fluids or intercourse? That was one question that was asked. And if there is any measurements about that.
No, I don't know whether I well understood the question. The question is about intermittent administration of mitotane.
No, the question is about like if somebody is on mitotane, can levels be, if you sweat on the levels or other fluids, can that be transferred? Or if this is going to be any toxicity to the person you're with, like with sweat or different fluids?
Yeah, the toxicity of mitotane is really very different from patient to patient. So we have to make a decision and manage toxicity as primary objective of the treatment. So mitotane should be administered in the best way in order to avoid any not avoid any toxicity. This is what I personally believe.
Okay, great. Thank you so much, Dr. Baruti. I really appreciate your time and your expertise. Again, we're really grateful that you're here with us today. Thank you so much for all of the work that you do for the patients, the ACC community, and for your continued efforts, because I know that you work tireless to help the ACC community. And with that,
thank you so much.
If you could stick around, so that way there's a few questions in the chat that if you can help us answer. But with that, let me then introduce Miss Kathleen Myers, as well as Miss Allison Fisher. Allison Fisher is an ACC survivor. Miss Kathleen Myers is an caregiver for ACC, and they're going to discuss the patient perspective and what are the important questions that you need to ask your doctor. Thank you.
Good morning. First of all, I would like to thank everyone for attending today. We have a great panel and we're looking forward to sharing a lot of valuable information. So thank you all for sharing your Saturday with us. For those of you who don't know me, as Dr. Del Rivero said, I'm Kathleen Myers. My husband, Mike, was a patient who had ACC. He was diagnosed at the beginning of the pandemic after being misdiagnosed with what we thought was a minor problem. He had experienced some symptoms which were attributable to the normal aging process, some weight gain, some slightly elevated blood pressure. He went to his doctor regularly. His doctor didn't see them as the red flags that they obviously were. And by the time he was diagnosed, he was stage 4 with metastatic disease in his liver. Because it was during the pandemic, he met with his local oncologist alone, as I sat in the car listening to all that she had to say on speakerphone. It was not ideal. We told our families, and my sister-in-law said that she had a friend whose daughter had been diagnosed with ACC a year before, Mike. And I was a little bit skeptical because, really, how could it be? It's so rare. It can't be right. Well, she was correct. And as it turned out, that new friend led me to the Facebook group, which led me in turn to Dr. Del Rivero at the National Institutes of Health. I emailed her on a Monday morning at about 11 o'clock, and she called me at 5:30 that same day and apologized for not having called sooner, but she had been seeing patients all day. Any of you who have dealt with Dr. Del Rivero know that this is very on brand for her. She is usually right Johnny on the spot at returning calls. So It was determined after reviewing Mike's scans and medical records that the tumor board and NIH believed that he would be a good candidate for liver resection, but it would be a big surgery. So on Columbus Day in 2020, Mike and I traveled to Bethesda for him to have the surgery. He had the surgery, and although it did not go as smoothly as expected, he came through it and he did well. His 3-month scans were stable and life was good. He was healing and he was able to get out and do some things as the pandemic allowed, because of course we were still in the pandemic. The 6-month scans, however, showed a recurrence in his liver, and back to the NIH we went for another surgery. Unfortunately, this one did not work as well as the first one, and by midsummer, it was obvious what the outcome was going to be. He passed peacefully at home, surrounded by family and friends and love. Now, you may ask why I'm still involved with this community, and I've been asked. It is because I believe strongly in helping people find better treatments and in providing patient and caregiver support. ACC is an orphan cancer, and because so few people, ACC is an orphan cancer because so few people are diagnosed with it. Local doctors are not researching this cancer. Experts are. If I can connect one person with one expert or another person that can help them, then this journey has not been in vain. And that is what motivates me to help all of you. So now I would like to introduce Allison Fisher. Allison is an oncological nurse practitioner and an ACC patient. You're up.
Hi, everybody. I'm Allison Fisher. It's nice to meet everybody. Thank you for having me here. I have a very interesting case and a very interesting situation just because I've worked in healthcare for over 20 years. So I've kind of gotten to see both sides just based on my background as a patient and being able to be just a little sensitive to some other things that people haven't been exposed to. But interestingly, even working in healthcare myself, as Kathleen mentioned, I actually came across all very similar as far as when I first found out what I was going through. I encountered very similar types of situations. Even being experienced in healthcare, it was really challenging for me to get on the right path initially. So I'm actually a 10-year survivor. How I ended up finding out that I had adrenal cortical carcinoma was I work with an oncologist, and I had a swollen leg, which led to a CAT scan, which led to, and I had high blood pressures, and I wasn't feeling well, which led to a further workup, which led to a biopsy because they did not know. I've never had cancer before. They did not know what they thought. I had 3 different cancers actually before I was really diagnosed with ACC. And I was almost treated for a couple of them, set up for treatment and everything. Anyway, that's why I feel so strongly with Kathleen about why it's so important to see an expert and be under the care of somebody who's really familiar with all of this, because the local people that I saw, I really struggled actually to find anyone that was actually even willing to treat me. So kind of navigating through how I got on the path of an expert was I ended up actually searching online. I did tons and tons of research, staying up all night in tears. I was kind of a disaster. And I ended up finding a story about my very, very good friend now, Tina Rubin, who actually lives in Michigan. And I saw a news story about her, and I contacted her, and I was fortunate enough that she referred me to the experts who, I will have to say, pretty much immediately from when I've seen several experts, because this has just been so difficult. And but I can just tell you from the minute that I went to anybody, they have been fortunate. They have been so willing to work with my doctors. And I've been very fortunate that I did find a local doctor who does gather all the information and he does help me, but he completely follows the guidance of the experts and respects them and wants to do whatever the experts say, because I'm the only ACC patient that he's ever had. So he's using it as a learning experience. But as far as my care goes, I'm so fortunate that he's so supportive and he reaches out to them all the time to confer on everything before he helps make a decision on what we're going to be doing. The other thing that I kind of wanted to just touch on was just the support groups that they have for us as patients. I'm usually a very private person and I don't really talk or post much on any of the groups, but I do have to say that the moderators, the patients, everybody, it's behind the scenes, it's so supportive when you're struggling and you just don't know where to go or what to do. There's so many resources on that page. Like Kathleen said, and Amanda, I mean, we can't actually take medical advice from those pages. We have to take it from our doctor because everybody's case is so individualized and so different. And that's another part that I've really experienced is whomever of the experts I've seen, I will say they've been so supportive and they really treat me like a person when I go. When I have been, I sit down, as many of you know, and they really treat me as an individual. Every single thing that they check and everything they do, they really have really catered the care to whatever my personal situation, because everybody is so different. Anyway, I'm very grateful that I did eventually get in the right direction, but like Kathleen, I'm just really passionate about trying to support people to try to make at least the beginning, or if you have a recurrence, to know where to go and what to do, and know that there's actually some very good resources that don't even strain you financially that are available. And so Kathleen and I are actually going to be talking about today why it's so important to see an expert and some of the different disciplines and different types of doctors and services that can support us as patients, and kind of to just get a little bit better understanding of what those are and a little more detail about them. Kathleen?
Yep. When I was thinking about this presentation, you know, the topic on the agenda is questions to ask. And I sort of think about things, and when I get an inspiration, I do a PowerPoint slide for it. And I've been doing this for 6 or 8 months. And when I was thinking about the presentation, you know, the topic is questions to ask. And I thought to myself, yes, questions to ask are good, but it's also good to know what doctors you might run into in ACC in treatment. And so I came across, I decided that we were going to go a little bit off topic. So I apologize for that. But here we are. So we have, I have slides about the different kinds of doctors that you'll see. So an endocrinologist is a doctor who specializes in the endocrine system. They know how hormones work. They know how your body should be functioning properly. They can advise on chemotherapy treatments, but oncologists have a more thorough understanding of cancer treatments and the effects on the body.
The next one is a medical oncologist, and the medical oncologist is kind of has the overview of cancer and the treatments and diagnosis. and all of the different types of testing. As far as the medical oncologists are usually really knowledgeable also about like the most current data and upcoming treatments and current treatments, and they are able to support pretty much almost every area of like of ACC. They're they're the ones who will refer you to the other specialists as well, for the other disciplines that we're going to talk about.
The next doctor that you might meet, and these are in no particular order, so, well, they're in a little bit of order, but not a great order, as a surgical oncologist. So a medical oncologist is going to recommend chemotherapy or other therapies, but a surgical oncologist will decide if it is appropriate for a patient to have surgery. For anyone who has not yet had a surgery regarding their ACC, I would strongly, strongly recommend and urge that you go to a surgical oncologist who has experience with ACC. This is not a garden variety cancer. ACC tumors are not just like other tumors, which is what a doctor told us. We didn't need to worry about it. I can tell you, if we had gone with the local surgeon, it would have been an extremely different outcome. So it would have been very, very bad. So if you need surgery for ACC, please, please find an expert and go to a surgical oncologist who has experience with ACC. And the other thing is that the experts are studying the tissue. If you go to a local surgeon, ask what's going to happen to the tissue and find out if you can have slides of the tissue sent to an expert, because research is not going to go forward if patients are not seen by experts.
An endocrine surgeon, the endocrine surgeons, many of us have seen an endocrine surgeon initially when we get our diagnosis that do our adrenalectomy, if we're a surgical candidate. As well, just to piggyback on what Kathleen said, the same thing is that you want to make sure that you go to a really experienced endocrine surgeon. And also, this kind of also goes hand in hand with having a biopsy, because when you have to be really careful when you see a surgeon, you want to go to somebody really experienced. And I'm sure that we've all discussed about having the implications of having a possible biopsy, which I'm sure that Dr. Del Rivera and the other experts would are the ones who are most knowledgeable on that. But that's one of the reasons why it's so important to go to an expert surgeon up front if you can, because right from the beginning, you want to get off to a good start, so that way it will set the stage for your whole disease process and care.
Now, this one is a hepatic pancreatobiliary surgical oncologist. This is a surgeon who specializes in resection of tumors, specifically in the liver, pancreas, and bile ducts. Liver surgeon is easier to say, and that is what I had always heard it referred to as, a liver surgeon. But the technical name is a hepatopancreatobiliary surgical oncologist. If you have to have your liver resected, as I said before, please find an expert that can do it. Please don't trust your local doctor.
The next one is the thoracic surgical oncologist, and they do different procedures, different surgeries. They review your scans again, because ACC is so rare and it's so specific and requires such a specific protocol. It's so important to see an expert. If you are needing any procedures in your chest or your lungs or any type of lung surgery, same as with any of the other surgeons for ACC, it's really critical.
The next ones that we have, there are two radiologists. So there's a radiation oncologist, and a radiation oncologist will assist with treatment in cancer. Again, it's really important that you go to somebody who knows about ACC. I just realized that we're about out of time for our segment, so I'm going to go quickly through these last doctor slides, and then we'll touch on a couple of the questions. We have a break from 10:55 to 11:15. So if it's okay with everybody, I think what we'll do is we'll maybe eat up 5 minutes of that break, and we'll get back on track that way. So there's the radiation oncologist, an interventional radiologist. One of the complications that my husband had was his kidneys shut down, so he needed dialysis. An interventional radiologist placed the port for the catheter for the dialysis, and an interventional radiologist is going to place your chemo port. That's a kind of doctor that you might come into contact with. A genetic counselor, you may also be in touch with a genetic counselor, particularly if you have children. If you are positive for the Li-Fraumeni gene, you may want to have your children tested. I know it's scary. I get that. But if you know that you have the Li-Fraumeni gene and you know you need to watch your children for it, you can be a little bit more proactive in fighting things because you know that they may come up. Oops. Also, we talked about a palliative care doctor. I don't want to eat up too much more of our time because we've eaten up a lot of time. But the slides, we will be publishing the slides, so you will be able to see them. So let's see. Allison, do you want to ask some of your questions?
So we put together a list of some of the questions for people to ask their doctor, and we listed them that we feel are really important when you go see your doctor. How many patients have you treated with ACC throughout your career? How are they doing now? Do they work with a specialist, which of course is what's really, really, really important to stress. This one I loved. If your person had ACC, who would you want to treat them if it was your family member? Do you have genetic counselor that I can work with? You want to know what types of testing they're going to do, blood work, scans, what hospitals they go to. Like Kathy mentioned, that's important, especially for the pathology and if you're going to have surgery. And how often they're going to monitor you and do scans and different testing.
So obviously we have a lot of questions here and we have a lot of material, more material than I gave it credit for. I thought we would run out of time. But as I said, I've got all of these slides. We will share them. If anybody wants them, let me know. If you have any questions, let me know. And it's 11 o'clock, so we will take our break and we'll be back at 11:15 with Dr. Raul Ribeiro from St. Jude's Children's Hospital. And thank you all for your time. We appreciate it.
Thank you. Thank you, everybody.
if I may say a couple of words, thank you so much, Ms. Myers and Ms. Fishers. You're really true warriors, and thank you for sharing your stories and for also sharing with the community and the ACC community. And I know for a lot it's a struggle when we're dealing with a rare cancer. You know, it's a struggle, it's the uncertainty, and we need more experts, we need more guidance on how to treat patients with ACC. Just to let you know, there is somebody asked for the agenda, so I'm hoping I can share the agenda within this break, so that way you can still see what is coming next. And again, if you have any questions, just put those questions in the Q&A part of this Zoom platform, and we'll answer the questions accordingly as much as we can. And again, thank you so much for your participation, and thank you so much for our constant source of inspiration. So thank you. So we'll be back in at 10:15 sharp. Oh, and I will share I hope I can share the agenda, Amanda. So help me, if not, maybe you can share it. So for our attendees to know what is next.
Yep, I'm trying to find the agenda. I'll have it posted in just a moment, everyone.
Should I share my slides now?
Yes, I'm going to stop sharing.
Can you see there?
Yes.
Thank you.
One more minute, less than a minute. We should be able to go. Okay, it is now 11:15. We're going to start with our next session of this conference. It is my pleasure to introduce Dr. Raul Rivero, who is a professor of medicine, and he's a pediatric hematology oncologist in St. Jude's Children's Research Hospital in Memphis, Tennessee. He is currently leading research efforts in the management of pediatric ACC. He's part of the children's cooperative group who had led some of the study, the chemotherapy study for pediatric ACC, and he continues his effort to the better understanding as well as the molecular underpinnings of ACC. With that, it's my pleasure to introduce Dr. Raul Rivero. Thank you.
Thank you. Thank you very much for the opportunity. And I am honored to be able to talk to you, particularly patients and families. And yeah, I don't have any disclosure or in conflict of interest, but I'm going to be talking about some of the medications used to treat pediatric adrenocortical tumors, which have not been formally approved for this use, we call off-label. I plan today to explain the correlates of changes, genetic change in outcome of ACT, how they correlate, and discuss the current treatment of ACT and identify opportunities to improve the survival of metastatic ACC. So pediatric ACT is a very heterogeneous disease, not only rare, but it's very heterogeneous and different from adult counterparts. And that has difficult a lot the progress in treatment of this tumor as compared, for example, with other very common cancers in kids like leukemia and others, that there are opportunity to study a lot of the mechanism because you have the numbers and do clinical trials. The disease is very rare, accounts for 0.2, 0.3 per million in individuals below 20 years. And ACT represents 0.2% of all pediatric malignancies. In southern Brazil, there is a excess of adrenocortical tumors in the population, looks like 15, 20 times more common. And that is due to a TP53 variant in that population. And that actually offers an incredible opportunity to study some of the characteristics of adrenocortical tumors in pediatrics. More than 80% of pediatric tumors are secrete some of the adrenocortical hormones, including androgens, cortisol, aldosterone, very rarely estrogen. Non-functional ACT is more common in adolescents. To convince you that pediatric ACC or ACT is a little bit different from adults, here a distribution of a germline. Germline is when the child has already a mutation in all cells of her body, or Li-Fraumeni is called also Li-Fraumeni syndrome. So it accounts for 50% of the kids between 0 4, 75 between 4 and 12, decreases in adults, accounts for a minority of patients. So, and also these cases that don't have p53 have other mechanisms that are different from the disease in adults. Another difference, even inside the young group, is age. Age is an independent prognostic factor in adrenocortical tumors. Children below 4 years of age have a better prognosis than the patients diagnosed after 5 years of age. One reason is that patients in this age group has less metastatic diseases at diagnosis, and that starts to change and is relatively more common in adults. So I mentioned to you about the TP53 mutation, and as 50% of the patients in pediatrics. And the other common genetic abnormality in these patients is the so-called mosaic or imprint, changes of the imprints of the chromosome 11 p15. This here type is also called Beckwith-Wiedemann syndrome. And these many times don't have a complete syndrome, but some cells of the body express more IGF-2 and causes the adrenocortical tumor if adrenal gland carry those cells. So that you can see here that about 70% of the patients with adrenocortical tumor in pediatrics have either Li-Fraumeni, Beckwith-Wiedemann syndrome, or mosaic UPD, uniparental disomy. The ending results of having these abnormalities is that increase the IGF overproduction. So 75% of the patients in pediatrics, the tumor is driven by expression of IGF-2. The other groups have other mechanisms, but many of them involve the beta-catenin pathway which is relatively also important in pediatric ACT. So I'll share with you one patient I had 2 years ago. And the mother called me. She was being treated by an oncologist in her state. Was a 13-year-old girl with diagnosed with adrenocortical carcinoma stage 3 in high DHEAS, typical more or less the adrenocortical tumor. The tumor was very small, and the Ki-67 was relatively low, didn't have P53 mutation, didn't have another genetic marker that is associated with poor prognosis. It didn't have the beta-catenin involvement. So the decision presented to her was to use conventional chemotherapy, platinum, etoposide, and mitotane and anthracycline, or radiotherapy or mitotane alone. This is a 13-year-old in oncology, was cheerleader. The mother was very concerned when she discussed with the physician the potential side effects. I said, asked the reports, all the data for us to review all the material in our tumor board, as we do here with all cases of consultation. And the history was really interesting. The first year of life, she had severe neonatal hypoglycemia, had some degree of microglossia, increase of the size of the tongue, mild right hyperplasia. One part of the body was a little bit enlarged than the other. Had enlarged pancreas, not surprising because she had hyperinsulinemia. Had a nephrocalcinosis and thymic hyperplasia that had to be surgically removed because was causing respiratory distress. First year was horrible. And during the following years, because with this symptoms, she was diagnosed with Beck-Wiedemann syndrome, but the test was negative for that. She had liver mesenchymal hematomas, biliary adenofibroma. At the age of 13, then, in addition of adrenocortical tumor, she was diagnosed. She had breast fibroadenoma in a pelvic mass that was diagnosed as lipoblastoma. The studies that we performed in genetic studies revealed that she had the so-called germline mosaic-wide paternal UPD. So the cells of the tumor, 100% of the cells of the tumor were from the paternal origin. They didn't have any chromosome of the maternal origin. So with that, we decided to observe only the patient. And she has completely normal now activity and has been free of disease for 2 years. Just to explain a little bit better what is this problem. So one cell during embryonal development lost the maternal chromosomes and duplicates the paternal chromosomes. This became part of the development of the child. It eventually distributed in the body in different areas. So that's what we call mosaicism. And these areas in the body, depending on the tissue, if the tissue is more susceptible to some of the substances that is controlled by the male chromosomes, will be then developing tumors. So the other problem in pediatric adrenocortical carcinoma is histology. 50% of the cases are classified as a carcinoma, 15% adenomas, and the remaining indeterminate histology. A common dialogue with my pathologist here is I send the tumor for review. She would tell me, I don't know exactly, looks like it's indeterminate. I can't tell for sure. And then I say, listen, there is a pulmonary mets. And then she'll tell me, it's carcinoma. So then it's very difficult many times for them to establish degree of aggressiveness based just on the histology. And we know that can progress in pediatric from adenoma to indeterminate carcinoma. Carcinoma is not an independent, a factor that is independent associated with prognosis. But the most important, and that has implications for how we study these patients, adenomas or indeterminate subtypes can be associated with the constitutional syndromes. So in our protocol in the COG study, Children's Oncology Group, for example, our study was central reviewed to treat, to enter the protocol, only patients with carcinoma. So we may be losing opportunity of many patients that have indeterminate or adenomas. There is a criteria you may have heard that is called VNAC criteria, based in 9 aspects. Tumor criteria based on these factors is 2 criteria will be benign, 3 uncertain, 4 or more poor. However, when applied to pediatrics, as I showed to you, does not consider age, genotype, or tumor rupture during surgery. So that aging we know has implication for prognosis, genotype has implication for prognosis, so that is missing a better classification of these patients. Here, just for illustration, this is a patient who does not have or does not carry TP53 mutation and develop adrenocortical carcinoma and very relatively large. But when we did the genomic studies of this patient here, the tumor is really quiet. You don't see abnormalities. As with the P53 mutation, you can see same size, same stage, the number of genomic changes that may confer a genotype with more aggressiveness and also chemotherapy resistance. Even large tumors, if there is no P53, many times the tumor is quiet, genomic is relatively quiet. In others, with P53, you can see visually the incredible difference. So for prognostic factors then in pediatrics, it's very important to establish the genotype. And what the patient here ask the physician, was the slide of my child sent for characterization of the genetic? This is very important. So this is a study that we did many years ago, but this was a relatively homogeneous population, and more than 80% of the patients have germline TP53. The stage is very important. You understand why. If these patients are small, we will not have time to acquire those abnormalities. And age also is important. If the patients are diagnosed early, within the first 3 years, and remove the tumor, even patients with a little bit more advanced disease will have better prognosis. It's independent. And that is the main importance, what was mentioned here before. Patients with P53 have to be screened. In first sign of the disease, intervened, because it can save the lives of the kids, because it avoids all those changes. So we're screening for pediatric adrenocortical carcinoma in a family that has one of the carriers positive for TP53 is so super important. So this was the study that is the only prospective study that exists so far in pediatrics, and was done by the Children's Oncology Group, opening 2006 and closing 2013. All the patients have finished therapy when we analyzed for more than 2 years. Patients enter if they had carcinoma only, what I think was one of the problems, and also classified by the Vienna criteria, because it's what we have at this point. And we ask the question whether, if we do retroperitoneal lymph node dissection at the same side of the tumor, if we would have a better prognosis. We didn't want to use chemotherapy. For these patients, we use that. For patients with advanced disease stage 3 and 4, we use mitotain in the combination ADP. Here is the treatment according to the stage. So stage 1 was surgery observation. Stage 2 was surgery plus retroperitoneal dissection. The other patients, we use chemotherapy in mitotain. So this is a graphic showing the event-free survival, means the patients were treated according to those guidelines, and we say the disease progressed or the patient died. This is considered event. So as you can see here, the number of events in stage 1 is very small. They are living without events for a long period of time. Interestingly, stage 3, that you would expect to be worse than stage 2, did better. And that because we did chemotherapy for that group. So the first response is that, yes, chemotherapy works for patients with stage 3. However, didn't do much for stage 4. So it's inefficient for stage 4. Now, when we look at survival, now the survival stage 2 approximates to that of stage 1 and 3, because in stage 2, the disease progressed, but we took the children again to surgery and gave chemotherapy. And the survival of the stage 4 is dismal. So here is the main message, the conclusions of that study. So the stage 1, we were expecting, based in retrospective studies, to have 90%, and we had 91%. So the classification of stage 1 was okay. The stage 2, the retroperitoneal lymph node dissected didn't show any signal of improvement. So the patients relapsed at the same rate that they did in the past. So chemotherapy was efficient for stage 3, as I mentioned to you, but no improvements in stage 4. The main problem with this study was the tolerance, what we called feasibility. So we planned to see if this chemotherapy, which had never been used in pediatrics before, combination of platinum, toxo, etoposide, and mitotain. So we want to decide if they were feasible. So we had 38 patients, stage 3 and 4, for whom we studied the tolerability. Patients who had mitotain stopped because toxicity, we count as a feasibility event. If they had a chemotherapy, at least one compound of the chemotherapy stopped because toxicity, we counted as a feasibility event for chemotherapy. MLF, mitotain, CFE chemotherapy. Mitotain held in 4 patients, was not tolerable in 4 patients, had to be discontinued. And that is 10%, 10.5%. By the criteria that we established before, if we're more than 10%, we would consider intolerable, because this 10% actually can be 24%. The same for chemotherapy. 12 patients, we had to modify the chemotherapy. And we established that if more than 20%, we would consider not tolerable. So the main issue of that study and the message was that the chemotherapy that combines these elements that I mentioned were considered intolerable. And we made a recommendation that we have to modify. Although in that particular paper, we don't specify because we didn't have any group control or anything to go about. So how I think we should manage patients with adrenocortical tumors in children. If ACT is suspect of all those doctors that were present to us, surgical evaluation to see if the patient is operable or not is the most important. Don't lose too much time in doing a lot of hormone studies and seeing proof to see if where it is. If has a suspicion in pediatrics, if you have a suspicion, immediately involve the surgeon. If it is possible, remove. Then surgery, pathology, molecular, staging, patient stage 1, patient stage 2, COG stage, TP53 negative, and paternal UPD positive, patient stage 1 with rupture, but is 53 negative, and age 4 you can observe only. Consider for chemotherapy patients with stage 2 and P53 positive. In other words, the tumor already grew, is heavy, probably acquired a lot of other abnormalities, or age after 4 years. In paternal UPD negative, or stage 3, or patients who had percutaneous biopsy, violated the cavity, spread tumor probably in the peritoneum, these patients go for chemotherapy. So the surgeon say, no, I can't operate this patient. If the patient cannot be operated, but the clinical symptoms is very classic for adrenocortical tumor, and then you can consider pre-operatory chemotherapy. For tumors which are non-functional, so then you have to do the biopsy, and those patients are considered for chemotherapy. So we need really a lot of studies, and we need to have an organization of trials for pediatric adrenocortical tumor, and these drugs need to be investigated. We at St. Jude now are developing a CAR T cell for advanced solid tumors, in the ACC expressed this marker. Take-home message: genetic changes leading to overexpression of IF2 and beta-catenin are common. Prognostic indicators vary between these two groups. All histological subtypes of adrenocortical tumor are biologically clinically relevant. We don't have that adenoma, adult adenoma, that stay quiet. Any patient with adrenocortical mass should be considered for investigation to prove otherwise. Unfortunately, there is no prospective control study of mitotain in pediatric ACT. A lot of small studies, a lot of conclusions based on that, but not really a study that was very well developed. The tolerance of this combination is poor in children and adolescents. and we need an innovative approach for stage 4. My colleagues, Carlos, Catherine, Emilia Zambetti, Ronald Figueiredo from Brazil, Enzo Lyle from France. Physicians will refer patients to the international registry. Importantly, parents, I noticed that there are patients in the group. I suggest that parents are important to be part of the group as well. They are incredible advocates for their kids as well. And I think it's an important component to St. Jude and to Children's Oncology Group. Thank you.
Great. Thank you so much, Dr. Rivero, for an amazing presentation and for your acknowledgement. It does take a village, right, to work together and make a difference. And I'm so grateful that there are people that, you know, for our ACC community, there are people that is really working hard to develop better therapies. I'm going to introduce our next speaker, Dr. Rivero, but please, there is a Q&A session, so please stay for the Q&A session after Ms. Haggerty. And there's a few questions that, you know, already in the chat, and as well questions that were submitted ahead of time. But with that, let me introduce Ms. Kelsey Haggerty. She's a pediatric oncology genetic counselor at Emory University, and she's going to talk to us about when is genetic testing recommended in ACC. Ms. Haggerty, please, the floor is yours.
Hi, thank you so much. Let me go ahead and share my screen really quickly. Doing it a little bit of a different way than normal. Okay. All right. Can you guys see that okay?
Yes.
Okay, perfect. Yes, thank you so much for having me, everybody. Like they said, I'm a pediatric hematology oncology genetic counselor at Children's Healthcare of Atlanta. And I'm really looking forward to talking with you guys today about genetic testing for people with adrenocortical carcinoma. But before, oh yes, I do not have any disclosures or conflicts of interest. Before we get into the nitty-gritty of things, because we all come from different backgrounds, I thought it would be important to give everyone a brief refresher on DNA, genes, and chromosomes. So as I'm sure you all are aware of, our bodies are made up of trillions of cells, right? Which are essentially considered the building blocks to life. If we were to zoom in on any particular cell, we'd see our DNA, which is essentially simply put, a very long string of letters or molecules called nucleotides. And if we think about things using the analogy of a recipe book, we can think of DNA as being the letters and the words on a page that work together to make that recipe book for our bodies. Now, different sections of DNA are called genes, and we can think of those as individual recipes within the recipe book, just as we would have a recipe for cookies and another one for cake. Every gene has its own purpose, and it determines how we develop, how we function, what we look like, what color hair we have, things like that. And then all of that information is packed into chromosomes, very tightly coiled, to make it much easier for that information to be passed down through generations. And typically we all have 23 pairs of chromosomes, and we inherit one set from each parent. Now, you can imagine that if there's an unexpected spelling change or a typo or a chunk of missing letters in a recipe, that could make the recipe really hard to follow or would provide incorrect instructions. The same is true for our DNA. Sometimes these things are called mutations. If too many mutations accumulate in the body, the cells can turn into cancer cells. Now, most of the time, cancer, as we know it, is sporadic, meaning that those mutations that created cancer cells in the first place were caused by factors that we either can or cannot control, such as our age, our race, certain lifestyle factors and choices like smoking, exposures, and other things in the environment. About 15 to 20% of the time, we see what's known as familial cancer, meaning that we might see cancer running through the family. We might be able to see some pattern, but we're not able to pinpoint an exact cause. And those types of cancers can be due to a combination or of hereditary and environmental factors. And then finally, about 5 to 10% of the time, we can see something called a hereditary cancer predisposition, meaning that someone was actually born with a DNA mutation that increased their risk to develop a different type, multiple types of cancers. So to define cancer predisposition a little bit more clearly, it's defined as an increased likelihood of developing a particular tumor or cancer due to specific genetic variations that are often, but not always, inherited from a parent. And there's a few different things that we look for to either increase or decrease our suspicion for hereditary cancer predisposition. Some of those things include individuals in the family diagnosed with cancer before the age of 50 or in childhood, multiple family members who have had cancer, or a family member that was diagnosed multiple times, as well as rare cancer diagnoses. For example, adrenocortical carcinoma is one of those. And so I'm sure many of you may be aware of this because some of you may have had this diagnosis yourself, but adrenocortical carcinoma is a rare cancer type, typically only seen in about 0.5 to 2 people per 1 million. And so it's not an exaggeration to say that someone with this diagnosis is 1 in a million. It occurs in about 0.2% of all childhood cancers, and even less than that in adult cancers. So it's known that about 5 to 10% of adrenocortical carcinomas are associated with a cancer predisposition syndrome. And like I said, those of you who were diagnosed with ACC may already be familiar with this, or maybe even were diagnosed with the predisposition syndrome. Leishmania, which we've been talking about a lot today, makes up about 2 to 4% of ACC cases, and upwards of 80% of children with an adrenocortical carcinoma. I'll talk more in detail about Leishmania syndrome, but for the sake of time, I'm just going to quickly go over the rest of the predispositions syndromes that we can see. So Lynch syndrome is seen in about 3% of ACC cases and is associated with an increased risk for colorectal, other GI, endometrial, and pancreatic cancers. And then these are some of the other predisposition syndromes that we can see: multiple endocrine neoplasia type 1, or MEN1, Beckwith-Wiedemann syndrome, which Dr. Rivera was talking about. And then rarely we can see familial adenomatous polyposis, neurofibromatosis type 1. And then there are a few case reports out there about Carney complex, Birt-Hogg-Dubé syndrome, and hereditary breast and ovarian cancer syndrome being seen in individuals who have ACC. So because of the impact that this diagnosis can have on patients and families, I did want to just go into more detail about Leishmania. So I'll refer to it as LFS, but LFS is caused by a mutation in a gene called TP53. This gene is known as the guardian of the genome because its primary role in the body is to protect us from developing cancer. When this gene is not functional, we can see an increased risk for lots of different types of cancers, including breast cancer, sarcoma, brain, leukemia, lymphoma, and of course, ACC. There's an extremely high risk for cancer throughout the lifetime, about 70% for men, and greater than 90% risk for cancer in women. And because of the inevitably high risk for cancer in these individuals, surveillance for this is quite intense, and essentially makes us want to scan the body head to toe throughout the year to proactively search for any signs of a tumor. This image here is from an article published by Villani et al. In 2016. This was an observational study of 89 patients with LFS who were followed over the course of 11 years. As you can see here, the red line shows that those who underwent surveillance for Li-Fraumeni had a 5-year overall survival rate of 88.8%. Whereas those, as you can see with the blue line, those who did not undergo surveillance had a decreased overall survival rate of 59.6%. More tumors were identified in the patients who underwent surveillance, but because they were identified at an earlier stage, they were more likely to be treatable. And all of this just goes to show that screening absolutely has the power to save lives. So in summary from that, due to the fairly significant possibility of identifying a cancer predisposition in these patients, because some of these predispositions, especially Li-Fraumeni, involve childhood onset tumor risk, and in the interest of prolonging a person's life with tumor surveillance, it's recommended that all individuals, and especially children with a history of adrenocortical carcinoma, should receive a genetics evaluation, even in the absence of family history. So genetic testing can provide a lot of really helpful information, but kind of the 3 big things that we think about are, number 1, an explanation for the diagnosis, kind of the answer to our why. Why did this happen? Why do I have this diagnosis? It can also inform treatment decisions, therapy plans, and as well as surveillance recommendations for the individual. And then 3rd, it can help further quantify cancer risks and inform surveillance recommendations for family members and future children potentially. So as far as who can order genetic testing, of course, a genetic counselor is specially trained to order this genetic testing for folks. But sometimes your PCP or oncologist or other medical provider can order this testing too if they're knowledgeable with it and comfortable with how to order the testing and interpret the results. A little bit more about genetic counselors. We are licensed and certified allied health professionals who have master's degree training in medical genetics and genetic counseling. Some of the things that we do are we provide risk assessments to families after taking a large personal and family history, kind of putting together the entire family tree to see how likely is it that someone might have a predisposition syndrome running in the family. We then order the genetic testing that we feel is most appropriate for that patient through essentially government certified laboratories. And then once those results come back, we are trained in how to interpret those genetic test results. It's, sometimes those results aren't super straightforward. So it's important to have someone who's especially trained in interpreting these results to look them over. And then we also help guide and support patients who are seeking genetic information, provide them resources, and can actually facilitate and coordinate surveillance with other doctors and coordinate testing for family members. As far as the logistics and how testing actually happens, it can be collected via blood, saliva, or cheek swab. And there's no difference in accuracy between those. Just sometimes for kiddos, we try to do less invasive testing with the cheek swab or saliva. And there's just some increased risk for contamination from like food and things like that. But overall, the accuracy is exactly the same. It takes about 3 to 4 weeks for the testing to come back at most labs. Most insurance types are accepted, including Medicaid and Medicare, as well as our private insurances like Blue Cross, Aetna, United, Humana, things like that. And genetic testing previously used to be very expensive, but has become more and more affordable over the years. And now typically with most of the labs that we send testing to, out-of-pocket cost is no more than $250, but is frequently much less than that, and sometimes even zero, because the labs work together with something called the NCCN guidelines, or National Comprehensive Cancer Network guidelines, to determine how much of the test will be covered. And if someone has an adrenocortical carcinoma, it's highly likely that the testing will be covered completely. And so if you're not sure about how to find a genetic counselor, you can just go to this website. It's called nsgc.org, or the National Society of Genetic Counselors. website. You can click on that button there that says find a genetic counselor, and you can actually plug in your zip code to find one that is near you. And nowadays, especially after COVID, a lot of genetic counselors offer both in-person and telemedicine visits. So you don't even have to necessarily drive very far to get this testing completed. They can actually sometimes send a kit to your home. And then lastly, some things to consider regarding genetic testing. There are many benefits, but there are also some disadvantages to be aware of so that you can make an informed decision. But some of the disadvantages include psychological stress, right? Because a positive result from genetic testing doesn't necessarily mean that you will develop cancer. But knowing that there is that risk for cancer can weigh really heavily on yourself as well as the minds of your loved ones. And communicating this information with family members, especially sometimes there are strained relationships with certain relatives, this can be a sort of difficult weight to bear. We can also receive an uncertain result that we're not really sure what to do with. But again, that's why it's important to have the testing ordered by a provider who's trained in how to interpret that uncertainty. And like I said, the genetic testing prices have decreased over the years, but cost is still a factor to many people. So that is something to consider as well. And then finally, there are laws in place to protect against health insurance discrimination. That law is called GINA, G-I-N-A, Genetic Information Non-Discrimination Act. But this doesn't yet apply to life, disability, or long-term care insurance for unaffected folks. Of course, some of the benefits of genetic testing are that it can really bring peace of mind to yourself and your family, regardless of the results. And having this knowledge may actually take away some anxiety or some fear of the unknown. This information can be very empowering as well. It can give you the opportunity to understand and be proactive regarding your cancer risks. And then sometimes this can actually be a lifeline to family members as well, because them getting tested can allow them to be proactive with their own care as well, and kind of give them a better understanding of their chances to have children or other siblings with a predisposition syndrome. So my last comment is just that adrenocortical carcinoma can be a really devastating diagnosis for patients and their loved ones, but genetic testing is always recommended so that we can assess treatment options, figure out surveillance and management plans, cancer risks for family members. And of course, it's always important to consider the benefits and the drawbacks of pursuing testing so that you can make the best decision for yourself. And that was all I had. I'm happy to take any questions, comments, looking forward to hearing potentially any experience that people have with predisposition syndromes or with getting genetic testing.
Great. Thank you so much, Ms. Haggerty, for very comprehensive and also, detailed information about how genetic counselor, genetic testing is done and the role of the genetic counselor. Thank you so much. I think this is important because this is a question that is often asked in our ACC community. Dr. Rivero, so maybe we can put you back on the stage so that we can answer a few questions. We are at the time of the lunch break, but I think if it is okay, I'm going to take a couple of minutes so that way we can answer a few questions. While waiting for Dr. Rivero, maybe you can ask a question to Ms. Haggerty. You earlier mentioned about the GINA Act, but that may be mainly in the US. What is your knowledge about something like that in other part of the world?
Yeah, that's a really good question. To be honest, I'm not familiar with insurance discrimination across the world and other parts of the country, but I am curious to know if other people have had experience with this or what they might know about it. Because like you said, yeah, GINA pretty much just applies to the US at this time.
Okay, thank you. And another question about genetic counseling is about that if the insurance does not approve genetic testing, what other avenues would you recommend in order to get it approved. Because that's also some of our patients may face that a genetic test may be testing, but then this is a rare cancer. So if there's no guidelines that recommend that, it may be sometimes harder to get it approved by the insurance company. What would you recommend in those situations?
Yeah, that's a really good question. I think so I know that as genetic counselors, actually part of our role is to actually work with the insurance as well. So that way, if any of the testing is denied by insurance, we can actually go in and submit a peer-to-peer or an appeal to that denial with insurance. And I've done a few of those myself because we believe it's extremely important for patients with ACC, especially to be getting genetic testing, and there's no reason why that should be denied. And so we fight fiercely for our patients to do that. But in the event that that doesn't work out, a lot of the labs that we work with also have policies in place where patients are able to potentially switch to an out-of-pocket cost, so that way they don't go through insurance at all. And then a lot of labs also offer patient assistance or financial assistance programs as well, so that if you can't afford genetic testing, there's a way that they can break it down for you based on income or payment plans and things like that, and potentially cover a majority of that cost. Great question.
I agree. Dr. Rivero, are you there? I just want to make sure.
Yes, hi,
Perfect. I'm sorry. So
no
thank
problem.
you so much. So Dr. Rivero, so there is a couple of questions I would like to ask you. And
Okay,
one of the questions that is asked by our ACC patients and caregivers is about surgery to resect metastatic lesions in ACC. And what are your thoughts about it? And we have patients that have lung metastases or liver metastasis, and in adult that can be done, but what are your recommendations in pediatric ACC, and if age also varies as well?
yes. So we also tend to do as much as we can in terms of surgery. For example, this week, a patient from Guatemala is coming to us, a 6-year-old, with a tumor that was considered inoperable there. So talking to the surgeon here, he accepted to take the child for a complete resection. I had 2 pulmonary mets, very well defined, one in each lobe. And then the plan is to resect the tumor, the main tumor, and see if we have or not chemotherapy here at St. Jude. But is wait for healing of this surgery and then go for the pulmonary lesions. Yes, we do a lot of metastectomy from the lungs and other organs, including sometimes liver, and working. One patient was registered from Atlanta, and this patient had a huge tumor, including 1/3 of the liver, several pulmonary mets. So the patient was considered inoperable, had the cabozantinib. The tumor shrank. They went to operate the primary, then the liver, no, then the lungs, and now will be in the liver while the patient is continuing with the same medication. So I think the pediatric pediatricians dealing with adrenocortical tumors know the importance of surgery and the very poor results of chemotherapy in stage 4 disease, 15% when you use chemotherapy. And many of these patients have a lot of toxicity, is not only not very effective, but in terms of quality of life is really poor. So we think surgery is a important component.
Great. Thank you so much, Dr. Rivero, for that. my experience, and maybe if any of our experts here today may also comment on that as well, is that whenever a medical oncologist or other specialties that are not familiar with ACC and they read about ACC and sometimes they see prognosis, sometimes, some providers may not necessarily think surgery is an option. And again, we're not saying, in a subset of patients, I think surgery is a very valuable option in a subset of patients. And I think it's always good to discuss with a multidisciplinary team. But usually what I have encountered, and I don't know if you encounter the same, is that, sometimes, physicians in the community, when they see a patient with ACC, I don't think that they explore those options in terms of surgery. So I think, I would like to know your thoughts, what you think about that. And if you feel like if every patient, with ACC could, depending on what, the stage of their tumors is, would you recommend patients to seek an opinion from a surgeon?
Yes, yes, yes. We work very closely with the surgeon. I always first person I consult and we go over the films is the surgeon. And he has here at St. Jude now a lot of experience in adrenocortical tumors. So we are fortunate that we can bring these patients from other places to St. Jude and offer them the best opportunity. And on the question of international P53 in adrenocortical tumors, if we have a consultation from outside of the country, we invite it to participate of the international registry. And as part of the international registry, we provide the P53 for the patients. If it's positive for the parents, if he is inherited for the other siblings as well, with no cost. So then, and we provide also genetic counseling for the patients and for the physician who is taking care of the patient, because many countries, they don't have a formal counselors. This is not yet established as a profession in many countries, genetic counseling.
Great. Thank you so much for that information. And I just want to comment because I get this question as well from patients, and Ms. Haggerty asked about that, and that's the Signatera and Natera. And thank you so much for the explanation, Mrs. Haggerty. But would you recommend doing that in patients with ACC? What are your thoughts about that?
53?
In patients with ACC, the Signatera and Natera. Maybe Dr. Rivero and Dr. Haggerty can comment on that. And maybe Ms. Haggerty, could you start about what are your thoughts about Signatera or Natera, and if that's something that you would recommend in all patients with ACC?
Yeah, you can go ahead, Dr. Rivera. I was just
go ahead.
This isn't, it's not a genetic test, as I'm sure folks know. It's essentially a test that's used to determine how many cancer cells are still left in the blood after treatment and things like that. I'm not super familiar with when and what cancer types this testing is typically done. I imagine it can be done in something like adrenocortical carcinoma, but may be used more so in other types of cancers to help kind of figure out if the patient needs additional treatment or therapy to get rid of those cancer cells.
Yeah, we don't offer to our pediatric patients, and I'm not sure, I don't remember seeing any study of circulating adrenocortical tumor cells as a help for the staging, for example. Will be, I think, interesting study to see if patients with stage 2, if they have any evidence that these cells are circulating, and these are probably the patients who need additional therapy.
Yeah, that's great information. So it seems that Natera is the name of the test, which is done by a company. So this is from Catherine Lamy, who asked that. Yes, I mean, I don't think we're prime time for ACC. I don't think it's a standard that is recommended, but good question. And maybe something that can be done in the research setting, like Dr. Rivero say, maybe for those stage 2 ACC, maybe if there is any circulating tumor cells, maybe that could help in terms of recurrence or give us a better understanding. But for now, it's not something that is a standard. But thank you so much for explaining, Mrs.
No
Hager,
problem.
Mr. Rivero. And now a question for Dr. Rivero. After ACC in a patient with pediatric ACC with metastatic disease and patient had received ACC because as ADP, because that's usually the standard first line therapy. And if there is growth of tumors after EDP, what will be your recommendation as the next line of therapy?
Yes, this is a very important question because, for example, in the adult setting, if you go to clinical trials, you see a lot of clinical trials in adrenocortical tumors in adults, but you're not going to see any in pediatrics. So we don't have a ways of recommending this patient for phase 2 studies or phase 1 that is dedicated to pediatrics. I now, for the past 3 or 4 years, have changed a little bit how I treat patients who are refractory or progressive. There is a possibility of using immunotherapy with nivolumab, ipilimumab as a potential, and cabozantinib as well. For me, I'm trying to recommend those medications for patients with resistant or progressive disease. But we don't have any study or any that we are sure that is definitive best option for this patient.
Well, thank you so much for the information and for telling us. But as yourself, there are research ongoing.
Yes.
Yeah.
So the way I interact with the families and patients and with adrenocortical tumors, I work with the local physicians because they refer the patient to registry, and then we follow up with them, and every year we talk about the patient, if the patient has any complication. So when the patients relapse, typically they will discuss again and ask for opinion. So my suggestions in the recommendations at this time is to use either cabozantinib or nivolumab, ipilimumab. There is a question about here the steroids, right?
Yeah, what are your thoughts about, because in
Yeah.
pediatric ACC,
Yes,
majority of pediatric ACCs, they have functional.
yes. So,
Yeah.
so in patients with, like say, Cushing cortisol, if I have to recommend one or another, I would prefer cabozantinib because that hypothetical issue that the steroids can inhibit the immune system, and probably immunotherapy would not be so effective in that group of patients. I don't know if this is true, but it's something that I think alters the immunity. I remember a patient that marked me a lot in the initial years, a patient with predominant cortisol tumor that presented with disseminated strongyloides stercoralis. Patient came with diffuse, including the lungs and everything. So looks like alters the immunity in some way that may not be a good candidate for immunotherapy.
Would you recommend blocking the cortisol? Maybe what we can do is, because now we have different cortisol blockers, maybe what we can do first, if a patient has an ACC that is producing cortisol, maybe we could block the cortisol first, and then after that, consider.
Yeah, I think this would be an interesting option.
Right.
Particularly if CAR T cell
Yeah,
prove to be important for these patients. I think would be important to be maybe blocking the steroids first before collecting the T cells and preparing during inoculation using blockage. Yeah.
that's great. Yeah, this has been an amazing morning. Thank you so much. And for your expertise. Thank you,
Oh, my
Mr.
pleasure.
Rivero. Thank you, Dr. Rivero. We encourage to stay so that way, because our patients, as you can see, asking a lot of questions, and thank you so much for your time. I know it's a
No problem,
Saturday.
no problem.
And
No
thank you
problem.
so much for your time dedicating to the ACC community. And I
Okay.
know we took a little bit of the lunch break, but we're going to be back at 1 p.m. sharp
Okay.
for the next session. And enjoy your lunch, take a break,
Thank-
and thank you so much. And we'll see you in 45, less than 45 minutes, 40 minutes, okay?
Okay, I'll be there.
Thank you.
Thank you.
Bye,
Bye.
Gary. We'll
Bye-bye.
see you soon. Thank you.
So do we leave and enter again or just leave on?
I'm so sorry. I think you could stay here. I mean, I'm sure maybe some questions will pop again.
Okay, okay.
You,
Okay.
you can stay logged in.
Yes, log in, yes, and we advise that, and thank you so much, as well as Dr. Barudi, Dr. Torsolo, and Law Creation, Dr. Wyman, for your time. Thank you. Patients are really grateful. So what I will do is, should I share again the calendar, Amanda, just to make sure that they know what is next?
Yeah, I think that's a great idea. I can as well if you'd like me to.
And maybe if you could also add a question in the chat, like please keep asking questions so that way they can, we can still, we're going to be here. So maybe some of us may be able to answer any questions as well. And whoever is
Good.
listening, please keep putting your questions in. We're here for you. We're here to answer any questions you may have. So just please keep adding on the chat.
Sounds good.
And so,
Thank
okay,
you.
I'll be right back. Okay, we're almost time. Well, we're out of time. It's 1 p.m. Eastern Standard Time. I just want to share something very quickly. I just wanted to acknowledge our caregivers, our patients, and of course our caregivers for all you do for the community as well. Not only for your loved ones, to be a support for your loved ones, but also for all you do for the AC community, and also for sharing your time with us as well. And with that, I just wanted to introduce our first speaker of the second part of the session, which is Dr. Margaret Wireman. It is my pleasure to introduce you today, Dr. Wireman. She's a professor of medicine, OBGYN, and integrative physiology at University of Colorado. She's the director of the pituitary and adrenal tumor program, also University of Colorado. She's a physician scientist that in one of her efforts is to understand the molecular mechanism of adrenal cancer. She has been the leaders of many committees of different organizations within the endocrine societies, among other organizations. She's an expert in adrenocortical carcinoma. Certainly, I continue learning from her. She's really wonderful physician and really wonderful understanding of how to manage adrenal insufficiency. I have to say, if I have any questions, it's always good to refer somebody like her with so much expertise. And with that, Dr. Wireman, the floor is yours.
Can you see the screen?
Yes,
Okay.
we can. It's not on PowerPoint, but yes.
Okay,
Now
we'll
we
get
don't
it.
see it. Yes, now we don't see it. Could you display the settings? Yes. SWOT presenter.
Is that good?
No. Oh, yes, now it is.
That's great.
Thank you. Thank you.
Thank you very much, and thanks to the organizers for asking me to give you an overview. And the topic I've been given is dealing with adrenal crisis and effective management strategies. I don't have any conflicts. So I think we have to go back to sort of the basics. And anyone who has adrenal cancer or has a family member with adrenal cancer, there are usually eventually problems with adrenal hormone production. Initially, at the beginning of the disease, we heard that about 60% of adrenal cancers make too much cortisol, and we use drugs to block the cortisol. But later, after treating the disease, often the mitotane we're going to talk about will destroy the normal adrenal glands as it destroys adrenal cancer cells. And occasionally, exogenous drugs with chemotherapy or too many pain meds can turn off this control tower in the brain that makes ACTH. So it's called the hypothalamic pituitary adrenal axis. Now, when you think about what cortisol is coming from the adrenal gland, it's the stress hormone. But stress, not like you're having a fight with your partner, but stress to deal with the physiology and stresses of the body. It controls blood pressure, it activates salt retention and can cause potassium loss. And the take home is too much cortisol is bad. If you're making too much cortisol from the tumor, it causes Cushing's syndrome, but too little is bad. And here are the list of the different areas in the body that cortisol has its effect. Now, when we talk about adrenal function, in a non-stress state, our two little adrenal glands above the kidneys make about 8 to 15 milligrams per day of cortisol. But in the stress state, cortisol production may increase up to 10-fold. And that becomes a big issue when your adrenal glands are gone or don't work, and we're giving you baseline steroids, and you need to be ready to increase those in time of illness. So we call it primary adrenal insufficiency, and the lab tests show high ACTH from the pituitary saying, wake up, adrenals, and the cortisol is low. And the most common causes, oops, it didn't go for the top one. Most common causes of primary adrenal insufficiency. Maybe it's going to come. Central ACTH will do that first. Low ACTH, low cortisol. That's the patients we see with pituitary tumors. If people are taking lots of exogenous steroids and then they stop them, you can have ACTH deficiency, traumatic brain injury, or with a lot of pain meds. Let's see if it's going to do, okay. The most common cause historically for primary adrenal insufficiency long ago was TB, but now Addison's disease is an autoimmune destruction of more than 98% of the adrenal. Bilateral adrenalectomy, if you have tumors on both adrenals, that will also cause primary adrenal insufficiency. And our major focus is discussing how mitotane causes primary adrenal insufficiency. So let's go back to this picture. And here we have the ACTH and we have the cortisol production. And the way mitotane works is to destroy all adrenal tissue. It destroys normal tissue, and importantly, it destroys or stops the growth of adrenal cancer tissue. And it eventually, over time, results in adrenal insufficiency, high ACTH, low cortisol. So most people, if you've been on mitotane more than 3 months, this is not reversible when you stop mitotane. But many people have adrenal insufficiency and live normal lives. So we deal with that side effect of the mitotane to be able to have a potential effect on tumor growth, recurrence, etc. So what are the signs that you're not getting enough cortisol? Nausea, vomiting, diarrhea, dizziness, fatigue, weight loss. It's an important thing to remember that as we treat patients with adrenal cancer with mitotane, it usually takes somewhere between 4 to 12 weeks for mitotane to destroy the normal adrenal tissue. And you'd think we would just measure the cortisol to figure when that is. But it turns out that mitotane screws up the measurement of cortisol. So we actually follow that ACTH, and when it starts rising, and patients have symptoms, we know they need some cortisol replacement. We also look at their chemistries. The important take home for all patients taking mitotane that's often missed by oncologists is that it makes medications be metabolized more quickly. And often patients on mitotane need larger doses than our usual doses we give for people with autoimmune adrenal insufficiency or Addison's disease. So how do we give back the cortisol when it's not working? Cortisol deficiency, the lack of the abilities to make enough cortisol for your blood pressure to be there, for you to fight infections, to feel normal. Historically, we treated people who didn't have adrenal glands with hydrocortisone. And in Europe, hydrocortisone is still the major therapy, and in many places in the United States. The normal replacement is 10 in the morning and 5 in the late afternoon, 5 p.m. about. Historically, we gave 20 and 10. It's usually given at 8 and 5. But the problem is when we're treating patients with adrenal cancer, it has a short half-life. So that may be more physiologic, but if you miss a dose, and I sure couldn't remember to take a dose every day, you can have increased risk of adrenal insufficiency, i.e. a low cortisol. When mitotane, again, mitotane makes meds metabolize more quickly. So if you're on mitotane and you're taking hydrocortisone, you need to give usually higher doses and more frequently, even 10 to 20 every 4, 6, or 8 hours. And that often is missed, and patients go into adrenal crisis on hydrocortisone, in my opinion. So at the University of Colorado, when we got into this field, we said, how can we make the lives of people with ACC closer to normal? Could we develop a twice-a-day regimen instead of taking meds all across the day? So we tend to use prednisone, and the normal dose is 2.5 to 5 milligrams a day. It lasts 24 hours, and we usually take it with food in the morning. But the problem is with mitotane, again, the half-life is shortened. So we usually give 5, 2.5, 5, or even up to 7.5 twice a day, breakfast and supper. Later in the course of mitotane, a subset of patients also stop making the hormones on the inside of the adrenal, mineralocorticoid deficiency, and they need fludrocortisone or Florinef, and the doses are 0.05 to 0.1 twice a day. And that's often missed and often a cause of dizziness, fatigue, and not feeling well. And we can pick that up with a low sodium and a high potassium. So how do we prevent adrenal crisis? Well, first we educate you and all your family members about stress dose changes. The dose may need to be increased during illness, fever, and stress. And again, not stress like fighting with your family member, but real stress, additional kinds of stress. And everyone needs an emergency glucocorticoid injection kit. And they may be different in Europe than they are in the United States. There's several different brands. And the problem right now in the United States is they're not pre-filled. So you have to have somebody be able to get it out, put it in the syringe, and then give it subcutaneously or IM. Some people can't do that. And I say, if you get that sick, just go to the emergency room. But of course, emergency rooms cost. It's very critical to wear your med alert bracelet or your necklace that says adrenal insufficiency, because if you were in a car crash and you were bleeding out, you can't bring your cortisol up. But if the medics see your bracelet, they will give you a shot of hydrocortisone. So wear your med alert bracelets. Now, what happens? What are the sort of recommendations? If you're home and you have a little bit of a fever, you can see the two temperatures, you double the dose for 2 or 3 days. If you have a higher temperature, you do 3 times the dose and you stay hydrated. If you're sane, but you can't keep anything down, you really should use your injectables, sub-Q or intramuscularly. If you're going to have surgery and you call your doctor and say, what should I do? If it's minor or moderate, we give on induction, for example, colonoscopy or a minor surgery, 25 to 75 over 24 hours. And usually it's on induction and then repeated at 6 hours if needed. If you're having major surgery or trauma, you have stress dose steroids, 100 IV, then 50 every 6 hours in the ICU. So there's a stepwise change in how you give steroids, and we try to give it and then stop it as soon as possible because we don't want to keep giving too many glucocorticoids. Now, the current recommendations for adrenal crisis in the hospital is hydrocortisone. It's called Solucortef. In Europe, they may use Solumedrol, but you give IV, and then over a 24-hour, you can use an infusion or give it every 6 to 8 hours if you have Addison's disease. In mitotane therapy, you have to give it more frequently, or patients will get sick. You also have to give also fluids. And that's a big problem with getting sick. If you're on mitotane, you need to keep your fluid intake. And in the ICU or in the hospital, you're either getting normal saline or lactated ringers and then adjust. Again, the take-home message is that patients with adrenal cancer are different than other people with adrenal insufficiency because the mitotane metabolizes those steroids faster. Now, glucocorticoid pearls. Everybody's telling me I can't tolerate mitotane. And half the time, it has nothing to do with mitotane. It has to do with other parts of the regimen. Importantly, that the steroid dose is higher and more frequent, and mitotane causes metabolism. And if the doctor's taking care of you, an oncologist may be not as familiar as your endocrinologist part of the team of how to make that adjustment. But remember that these steroids, glucocorticoids, cause gastric irritation. So no matter how many times I say it, I'll find a patient who's taking it in between meals. You can't do that. Usually we give a proton pump inhibitor to block gastric acid, and we take it with food, not on an empty stomach. So I just end with what we use at the University of Colorado. When we get into this business, we said, can we make the regimen easier than taking meds every 3 or 4 hours? So remember that mitotane within the first 6 weeks causes central hypothyroidism. And in that case, we're giving thyroid hormone, levothyroxine, and we're adjusting the dose based on the free T4 level, not the TSH. So usually they wake up, they take their levothyroxine, they drink water, they wait 30 minutes. Then they take some kind of acid blocker, PPI, and they wait a little bit. Then they either take Zofran or Compazine if they get nauseated before the meal. And then importantly, they take their prednisone, their fluticcortisone if they're on it, and their mitotane crushed with a fatty meal at breakfast. Then they're free for the rest of the day until dinner. Then they take Zofran or Compazine. They take the other meds again crushed with a fatty meal. Unfortunately, we don't know how to predict how much mitotane an individual person needs. It usually takes 6 weeks to 3 months to get therapeutic. If in Europe, they push very fast and very high, but they don't have a good compliance rate long-term with the mitotane. I don't think there's much data. We taper up to 3 tablets twice a day, and then we watch monthly levels, and then we adjust accordingly. So with that, I'll thank you for your attention. I have given my email, and my associate, who is doing a lot of the basic science work here, Katia Kisseljak-Vasiliadis. Our group has developed the first 2 new adrenal cancer cell lines, and we now have 8 patient-derived xenograft models to start in a preclinical model so we can start testing new drugs to advance the field. That is our goal, new targeted therapeutics, and understand patient-specific responses. Thank you.
Thank you so much, Dr. Wireman, for such a wonderful presentation, and very important for our patients and caregivers who are listening, because that's a very common questions about our ACC community, about how to prevent an adrenal crisis, how to manage, how the symptoms as well related to mitotane and so forth. There is a few questions in the chat, Dr. Warman, but I will appreciate if you could, stay after Dr. Lockridge's session so that way we can have a dedicated Q&A, and a few questions has been asked. Thank you, Dr. Warman. And now I would like to introduce, it is my pleasure to introduce Dr. Lockridge. She's a neuropsychologist with expertise in the clinical assessment of cognitive pediatric cognitive neurodevelopment and neuropsychology disorders as well for adults. She's currently transitioning to her permanent position at the NCI as a staff scientist. Certainly the NCI is very lucky to have you. You have done an amazing work within the rare cancer community and as well as with the ACC community. And with that, Dr. Lockridge, the floor is yours.
Thank you so much. I don't look like, it doesn't look like I can share my slides yet. It says someone's still sharing right now. Oh, maybe that works. Let's see. Okay. Can you see my
Yes,
slides?
perfect.
Do I need to do anything, or they look great?
They look good. They look
Okay,
very
good. Okay, thank you so much, Dr. Del Rivero, and thank you to ACC Connections and everyone for inviting me to speak here. It was really an honor to get this invitation, and I'm just excited to be able to speak with you all today, and hopefully this will be the first of many interactions that we can have. I do not have any disclosures to report at this time. I'm going to just close this. I wanted to spend just a brief moment, talking about kind of setting the stage about the psychosocial impact of cancer. There has clearly been extensive research over the past several decades in both oncology and psychology that has shown that, unsurprisingly, there are significant psychosocial consequences for both patients and their families. However, one number that often shocks people is that 35 to 40% of cancer patients have what we would call a diagnosable psychiatric disorder. And these are usually in the areas of depression, like a major depressive disorder, anxiety or panic, trauma or stress-related, or what's known as sort of a somatic symptom or pain-related disorder. And what's interesting about this is that although these numbers might change and increase if a person is at advanced stages of cancer, they're actually not much lower when we think about cancer survivors, which indicates really for us that the burden doesn't change no matter where you are in the process, whether you're being initially diagnosed or you were diagnosed 10 years ago. And that's really important for us as providers because it really lets us know that services need to at times increase or continue long term. For patients with ACC, one of the interesting things is there have been very few, although they're increasing, sort of qualitative studies, really understanding the lived experiences from the patient voice, the patients with ACC. Those that have been done indicate that patients report more unhealthy days of just feeling worse quality of life and mood and depression score, and higher odds of depressive symptoms. And usually this is frequently due to just general disease burden, but also toxicity of therapies, difficulty doing self-care management activities, and just general caregiver and family support, and the other domains that come along with the rest of life. So for the next few slides, I'm going to discuss different ways that stress can present, signs to look out for, and some potentially sort of daily management strategies. And hopefully I can do all of that fairly quickly. I just wanted to kind of set us in a place where we're working from the same definition. This talk is generally about stress or distress, as it's often referred to, but many of the things I'm going to talk to can apply to anxiety or depression or other sort of more formal symptoms that you might be used to hearing about. The National Comprehensive Cancer Network defines distress as an unpleasant experience of a mental, physical, social, or spiritual nature that can affect the way you think, feel, or act. And one of the really important things that I wanted to stress here is that this really is on a continuum. You know, stress, anxiety, depression, any of these things can reach the level of a clinical diagnosis. But usually what that's doing is that's going to follow an evaluation. We'll usually have requirements for the length of time and symptoms that are present, as well as an indication that there's significantly impaired sort of daily functioning over a period of time. On the other spectrum of that, I do think it's important to note that stress, anxiety, fear, guilt, all of these things are normal feelings. They're normal adjustment. And frequently I work with patients who somehow are concerned to come to me because they don't want me to sort of pathologize or diagnose them. And that's often one of the first conversations I have is, this is a normal experience that you're having, and I'm not here to diagnose you at all. In fact, maybe what you need is somebody to validate that and tell you that what you're experiencing is right, spot on. With that being said, normal adjustments should not imply that you don't need help or that you can't seek it out, or that you wouldn't need support or therapy or any of the other things in between. So just wanted to let you guys know that there is a continuum that it operates on, and that everything is not a diagnosis, but that doesn't certainly mean that you don't need additional help and support. Now, as we move to discuss symptoms of the stress, I sort of broke these down into categories that we tend to use in psychology to assess them. And these are symptoms that might be familiar to you. They're not comprehensive, of course. Some of them might fall in the emotional domain, it's sort of things like anxiety, guilt, irritability, changes in mood. What we frequently see that people are not sort of always keen to, particularly because if you're already battling an illness, physical symptoms. So stress and depression, anxiety can absolutely show up as fatigue or lack of illness, restlessness, sleep changes, either sleeping too much or being unable to go to sleep at all, weight changes, including, you know, losing weight or gaining weight and all kinds of fluctuations, stomach aches, and pain. And this pain can be something very consistent, like a headache. But what we also see is patients often present with sort of a pain that it doesn't seem to have a source. I just ache here, I'm tense here, or it really hurts here. Even when you touch me there, it hurts, but I have no reason. I didn't hit myself, I didn't fall, I just hurt. The other domain that we see a lot of symptoms in is their sort of social and behavioral domain, which I think everyone's probably pretty familiar with. The tendency to withdraw or be impulsive. Changes in work patterns is a big one for people continuing to work. Some people are, you know, feeling less productive, less motivated, and that's certainly understandable. We also see people on the other side just sort of trying to bury the worry and doing more. Let me fill my schedule. Let me fill my time. Let me sort of overwork myself so that I don't have to think about what I'm going through. And certainly substance use here. And this can be substance abuse or misuse, but it also could just simply be an increase in substance use for you. I sometimes see people who, you know, rarely, if ever, had a glass of wine and now they feel like they need one, you know, once a day or twice a day. Again, that's not quite abuse, but it's a change. And the important thing here is just noticing what seems to have shifted for you, and that could be a source of your stress symptom. In the cognitive domain, we also see a lot of difficulty concentrating, difficulty remembering things. Sometimes we see people who have difficulty with decision making, and that could be very simple decisions. And that often leads to a lot of frustration with themselves of saying, I don't know why I can't decide this. I'm usually very decisive. We also see confusion and sort of rumination or catastrophizing, which is really just another way of saying you're getting caught in that thought wheel of thinking of the same thing over and over again, can't get it out your mind, can't sleep because of it, or sort of worried about the worst possible outcome all the time. And you can imagine what that does over time when that's sort of in your thoughts. It's really important for us to identify the ways that stress shows up for you, because each of these categories and stress responses, they really can correspond to sort of a complementary intervention. So the first one is sort of kind of the daily one. I always say relaxation strategies are your first line response. These are the tools that are with you all the time. You don't need much to put them into practice. So it's really helpful to try to utilize these as much as possible, since they're the most readily available to you. Relaxation skills are very helpful in addressing physical symptoms of stress. We often work initially with diaphragmatic breathing or belly breathing. This has really been shown to be very effective in slowing the stress response and reducing anxiety and panic. It's sometimes easiest to practice laying down if you don't do it regularly. I often tell people, place your hand on your belly, pretend that you're sort of making your belly as big as a balloon, inhale through your nose on maybe like a 4 count, so pretty slowly, like 1, 2, 3, 4. Exhale. You want to think about keeping your breath still enough and slow enough that your hand doesn't wiggle, but that now you start to see your hand fall into your belly as a balloon deflates. Again, I tell people this gets better with practice. I don't expect people to know how to control their breath or to even think to use it. But the time that we need some of these practices is often not the time to practice them. Mindfulness or meditation, this is an interesting one, because I often find people go, I don't meditate. It really doesn't have to be a long and drawn out sort of form. It could be just a mantra you say to yourself over and over again. Mindfulness is the idea of just sort of being still and noticing where you are, particularly if you're having kind of a panic or anxiety response in a moment. I often tell people, just pay attention to your senses. What do you see? Where do you feel? Where are you sitting? Where are your feet? What do your hands feel like? What do you smell? What do you hear? Oftentimes that's just enough to get our brain sort of out of that moment of stress and panic or rumination and kind of bring us back to where we are. Again, it's not sort of a long-term solution, but it's just enough for some of these daily moments. Visualization and guided imagery, I'm sure many of you are familiar with, but there are many, many tools free and available on the internet and YouTube that you could use either sitting down before you go to sleep. If you like to take a walk and be in nature, there are walking tours that will guide you through imagery. And many of you might be familiar with this, the idea of a progressive muscle relaxation, or otherwise known as a body scan. And this is really just tensing every part of your body, starting with your toes and moving up to your neck and your head, and then relaxing it. And this is kind of give you a good idea to scan your body, see where you might feel pain or tension and stress that's holding on. Very quickly, some of the behavioral strategies, those really kind of fall in 2 categories. I'll sort of flip-flop these a little bit. Healthy habits, we all know, are effective at reducing stress and just helping us feel better. So those are your healthy eating, your physical activity, your sleep hygiene. Social support is a little bit difficult, I think, to acquire or to really feel like you're getting at times. I often ask patients that I work with to ask them, where or from who do you receive support from? And this isn't just the people you see most often. really who's filling you up, who's helping you to reach your goal, who's making you feel valued, who can you be sort of open with about all of the things that you're experiencing without then feeling guilty that you're taking their time. It's also really important to ask yourself, are you getting what you need from your network? Are you getting what you need from your provider? Are you getting what you need from your spouse, your partner, your friends, your family? Every one person, there may not be one person that provides you everything, but a lot of times we can get a team of social support, and then you know who to call for what, or you know who you'd like to sort of have coffee with, or you know who you'd like to sort of have with. I also like to remind people that social support can be active, passive, or very important, unhelpful. Someone who's an active social support person for you is someone who's really engaged. They reach out, you reach out to them. They know your goals, they know what you need. They're trying to help you reach them. Someone who's passive is not necessarily, they don't mean well, but they're just maybe a person who calls once in a while. Maybe they have other things to come on that are going on with them as well, and maybe not someone that you rely on as much. It's also a good time to really think about the social relationships in your life that maybe are draining you. And this isn't often discussed, but it's important because I frequently work with patients who we identify social or work relationships or other relationships that are really becoming a source of stress and not sort of what you need at this time. I'm going to speed through just in the interest of time and questions. Cognitive strategies are something that can really address all the other things that the relaxation and behavioral strategies haven't touched on. Cognitive behavioral therapy is a form of therapy. It's one of many. It is not the only one that's effective, but it has demonstrated effectiveness and often serves as a foundation for other models. The idea behind it is that it's really a triangle. It's that your thoughts, emotions, behavior, everything's interconnected, and that oftentimes our thoughts can sort of skew our emotions and make us act in a way that's not going to be helpful for us. The idea behind the model is not to change your feelings. You feel how you feel, they're valid. It's also not to sort of tell you to think happy thoughts, because that's also a bit insulting. It's really the idea of examining your thoughts and saying, why am I saying things to myself that's hurting myself? Did I learn something in the past, or did I think that I developed a rule about how I had to behave that's also hurtful to me at this time? Some examples of that are sort of all or nothing thinking. We don't allow us to see shades of gray. Something's either great or it's terrible. We're either successful or we're failures. That's an example of that. Overgeneralization is just sort of overly negative thoughts based on one or two experiences. Maybe, oh, I didn't do well on a presentation. Well, everyone thinks I'm a failure. That would be an overgeneralization. We also oftentimes see people do this sort of mental filtering where we focus on a single negative piece of information and ignore anything else that's positive in that situation. So maybe you have an argument with a friend or a spouse, and you decide the relationship must be falling apart. It's not going well. We also see a lot of jumping to conclusions, and this can be in the form of mind reading or kind of fortune telling, where we think we know what someone's thinking, or we think that the worst is going to happen when it hasn't happened yet. So that just keeps us in a heightened stress state. We also see a lot of, again, catastrophizing, where you're sort of magnifying things, but this can also happen in the reverse, where we're minimizing the importance of positive information because we're afraid to kind of have that moments of hope and positivity because we don't want that letdown that comes after it. And I see this quite frequently, a lot of should statements. I should have done this. I should be more like this. I should be doing that. That really places people in this very rigid rule thinking behavior where any deviation from what you think you should do means that you've failed. And if that's something that you're holding on to quite frequently, you can imagine over time how damaging that is. Some questions to ask yourself: what evidence do I have that this is true? what can I control in this situation, and sort of what is out of my hands? Is my response helping or hurting me right now? And what if this does happen, this terrible thing that I'm afraid of? What will I do? How will I handle this? What steps can I take? That kind of shakes us up and kind of gets us into more of a problem-solving mode. And then lastly, I frequently find that people and patients I work with just don't give themselves nearly the compassion that they give others. So I often ask people, what would you say to a friend or loved one who just said what you said to yourself? And see how that changes the perspective a little bit. Just a few things. I got a few questions that I often get is sort of, how do I know when to seek help? These are things that you can do on your own, but how do I know when it's time to ask somebody? There's really never a wrong time. If you're wondering about it, thinking about it, I say go do it. However, certainly make sure you reach out if you're experiencing stress or anxiety that's lasted for 2 weeks or more, or you're impacting your functioning. You can't get out of bed, you can't go to work, you can't sort of be with your family. Also reach out sooner if you're feeling really hopeless, you're using substances to cope, or people often describe, I'm feeling numb, like things are happening and I'm kind of just walking around in a fog, like it's not real. That's probably getting to a pretty severe point. What if I don't have time for therapy? That's a big one. I hear this all the time. Important to remember now, there are actually many brief interventions, sometimes as few as 5 sessions, that have really demonstrated effectiveness for many patients. Also, telemedicine has increased opportunities for scheduling flexibilities. So there's always some time, and you can certainly work with the therapist to work with a schedule that works for you. And this is one that I feel almost negligible when I don't bring it up. Therapy is expensive, and are there affordable options? And I have to acknowledge the cost and burden of mental health care really cannot be understated. There are options that might reduce cost, including most people do offer sliding scales. Group therapy is another wonderful option because oftentimes providers are able to reduce the cost because there's more people in a session. Pre or postdoctoral student-led therapy is an option. I have to remind people that most postdoctoral students, they already have their degree, they've completed their training, and they've generally been doing therapy for several years at that point. So they are well trained and they are still supervised by somebody in the area. But because of their training level, they can often provide the services at a lower cost. And then lastly, there is a new initiative called SciPac that's sort of starting to take wave in, I think, 26 states now. And it's allowing psychologists to practice across state lines. What this does is it allows you access to more psychologists who might have different sort of requirements in terms of a compensation, but also it allows access to psychologists who speak different languages, psychologists who have specialty in working with the oncology population, and psychologists who might have ethnic, racial, language, or gender identities that you sort of feel more comfortable with. I hope I didn't go too fast, but I'm trying to take care of the time, but I'll open to questions and answers now.
Thank you so much, Dr. Lockridge, for really a very wonderful presentation, and also to provide information to our patients. As you well said earlier, having any cancer diagnosis just originates a lot of anxiety, stress, and having a rare cancer is even more because it's a lot of uncertainty of the expertise or who to go. But the fact that there are tools, I think it's important for our ACC community to learn about that. And also, like, they're not alone. And for our patients and caregivers, I just wanted to tell you, you're not alone on this. And there are supports that we can provide, and it's okay to ask for help. I think it's important to know that. And I appreciate that. And with that, I want to open for questions. I know there is a few questions that we wanted to ask both of you, Dr. Wartman and Dr. Lockridge. So maybe, thank you, Dr. Wartman. And there is a couple of questions that I also been getting also via text as well and emails. And I think this is an important question because I don't think I had this question before. And it's about during chemotherapy, when the patients are getting chemotherapy. And the question is, would you recommend any different when the patient is getting steroids? Would you increase the dose of steroids? Would you give any steroids during the type of chemotherapy, maybe during the week or after the IV chemotherapy is given?
Again, most of the chemotherapy regimens, the oncologists are so used to blocking any kind of nausea with huge doses of dexamethasone. They get more than enough steroids around the time of the chemotherapy. Obviously, if they go home and they have persistent nausea and vomiting, usually the oncologists are giving them a lot of anti-nausea meds and anti-vomiting meds. So unless there are signs and symptoms of adrenal insufficiency, in addition, most patients across the times that they're getting chemotherapy probably don't need a big bump in their steroids.
Okay, great. Thank you
At
for
least in
that.
my opinion.
Great, thank you for that answer. And then you mentioned also in your very, very nicely beautiful PowerPoint, but I think that one of the questions here is there is a dosing method or schedule for mitotim that help reduce side effects such as fatigue, brain fog, and digestive issues. And one of the questions is about mitotim. Can you take it, once a day instead of all together? What are your recommendations about that?
Yeah, there haven't been any controlled studies. I mean, there's a study from Europe that says that if you push it fast and aggressively, you get therapeutic levels, the 14 to 22 that we're aiming for, more quickly. But again, in that paper, they had a huge dropout rate. And my goal is not to have, in the last 10 years, we've had 3 people drop out of mitotane. So I want my patients to take mitotane, and I work with them to get them to do it. It doesn't mean that twice a day is the best for everybody. Some people feel nauseated in the morning and do lunch and supper, and I think that's okay. There's actually the pharmacology and the underlying mechanism of mitotane is still pretty much hand waving. And so getting that, and whenever I say people are having side effects of mitotane, I look, are they taking their prednisone with food? Are they crushing the thing? Are they taking an acid blocker before? And if they are tendency to get nauseated, are they taking Zofran or Compazine before? Then I look to say, have we not treated their thyroid hormone deficit? And they're just so sluggish and fatigued because their T4 is in the normal range, but we want it, it's central hypothyroidism. So we want it in the top third of the normal range. And then lastly, are they one of the people who have developed mineralocorticoid deficiency and they get dizzy in the afternoon because they need Florinef, fludrocortisone twice a day. And then they perk up and they feel better. So it's not perfect. And lastly, you get the neuro and the really weirdo things when you get above 20. So if since we do monthly levels, if the levels are going, I back off a little bit because I have to wait 5 or 6 days for that mitotane level to go back, and I don't want them to get sicker and sicker. And so we go back and we adjust up. And they're all the things that interact with mitotane levels. I don't think anybody knows. So we're just constantly adjusting, and each person, some people will stay very nice and even, and some people you're going to have to adjust every month.
Yeah. And I know, and thank you so much for that wonderful explanation. And for our patients and our caregivers, you mentioned about central hypothyroidism. Maybe could you explain a little bit about that and when
Sure.
will be adequate time to give replation in those
Yeah,
situations?
so again, the majority of people in the world who have an underactive thyroid have an underactive thyroid. And the pituitary says, wake up, you stupid thyroid, and the TSH level goes up. And then we adjust the dose to a normal TSH. For some reason that's not unknown, mitotane causes central hypothyroidism. So the TSH is normal or actually low. And some doctors will say, oh, you can't have any thyroid hormone, but the T4 is low. So we have to give the dose and follow the free T4 levels. And every time you start thyroid hormone, it has a half-life of 7 days. So it takes about 5 weeks to restabilize. So again, in our practice, we check the free T4 and the mitotane levels in a chemistry panel monthly. And then the oncologists check whatever they need if the patient's also on chemotherapy or immunotherapy, which we really haven't talked about much.
Great. Thank you so much. I just want to give a question to Dr. Lockridge, and We'll go back to you, Dr. Wyman. And I think this is a very important question that I also get asked a lot. Could you, Dr. Lockridge, could you please explain the difference between palliative care and hospice care, and when is one or the other indicated?
Okay, yeah, that is a good question. The terms are often used interchangeably, but they're actually not. So hospice care focuses on quality of life rather than length of life. And many of the eligibility requirements are determined by the insurance company. So they are going to provide sort of compassionate care for people in the sort of last phases of an incurable disease, and make sure that as long as they can show that the person is not expected to live 6 months. And so that is usually what hospice care is, and that's when Medicare and other insurance companies will pay for that and provide that. Palliative care is a bit more of a broad term, and it encompasses hospice care, but it also encompasses non-hospice care. And so now it's really kind of focused on interdisciplinary care that really provides support, not just for patients, but for caregivers and family members as well. And the support will range from physical to emotional to spiritual support. For non-hospice palliative care, any person can be eligible as long as they sort of meet other eligibility criteria. So they have, a chronic complex disease that negatively impacts quality of life. Their disease symptoms are stressful, or they need very specialized care. Perhaps it's progressing, or perhaps it's not, but it's causing a lot of pain. And really now the best practice is that for non-hospice palliative care, that should be started as soon as possible. At times, the recommendation is to go ahead and start it at the time of diagnosis if you suspect that the patient's disease course is going to be really burdensome. And so that is really the recommendation now, is when to start non-hospice palliative care. But hospice care, the important thing just to remember is that if you expect the patient to live 6 months or less, that is now considered compassionate care. I hope that's answered the question.
Yes, thank you. And I do get these questions, and whenever we in the situations when we see a patient and we say, well, maybe we can consult palliative care, some of the patients feels a little bit like, oh no, because they have the idea like this is
Yeah,
it.
because it's been used so interchangeably now that I think it automatically gives a fear response of, wait a minute, what else are you trying to tell me, or what are you not telling me? And I think there's been a shift to try to change that. But that's very difficult. We get the same response of, why are you sending me to palliative care? And it's terrifying. I think it's terrifying at any level. But the current recommendation is actually to start it sooner rather than later, because there's so much wraparound support that can be given. And I'm just saying some things in the chats, when people are looking for additional services, support, therapy, social work, that is also now part of the palliative care. And so that can be requested through that team.
Would you say that palliative care can be requested at any time on their course of the diagnosis, whether it's cancer or not? And could we say that palliative care could also help somebody to live the best life having a diagnosis of cancer? What would you say about that?
They could. And actually now I actually just did another presentation about this. They do recommend that now, even at the initial point of diagnosis, that you can consult palliative care. It's going to provide another source and contact for you to help get the best sort of full care for the whole person. And so it really can lead to sort of improved quality of life for many patients, especially and the important thing for non-hospice palliative care is that this could be curative, or it could be just sort of long lasting. There's no sort of timeline on it. So the important thing is now you're just getting services to help you improve the quality of life and sort of live the best life. So we highly encourage to contact palliative care as soon as indicated. Yeah.
This is great. Now let me go back to Dr. Wyman, because there's a few questions here as well.
It's Maggie Weirman.
Maggie Weirman, sorry.
No problem.
So as a man, do you find that supplemented testosterone will increase the energy level? So maybe we can rephrase in a way that if a patient have low testosterone, with cancer, whether it's ACC or other, would you recommend supplementing with testosterone?
So first of all, besides the other side effects of mitotane, it can cause hyperlipidemia. It can cause low testosterone in men or high testosterone because of the SHBG changes. And it can cause irregular periods in women and estrogen deficiency. So if a testosterone is low, yes, we give it back at physiologic doses, not at pharmacological doses, usually with a testosterone patch, the patches aren't available, gel daily. In women, it's tougher because often you're worried about hypercoagulability and risk. And so often if we have someone with very irregular periods, we will try to put a Mirena IUD in or Skylar. And then if their estrogen gets low, add the estrogen patch. So we try to not give them a birth control pill dose of estrogen, but if they're really not completely estrogen deficient, we protect their endometrium, especially if they're a Lynch patient, and sort of deal with that one by one. But using testosterone as an anabolic steroid, I don't think there's any really good data of that, and you may increase the risk of hypercoagulability.
Correct. So meaning forms of blood clots. And I think I'm following that question for our patients and our caregivers. We know that mitotane, like you mentioned, can increase what we call a sex hormone binding globulin. So meaning that when the testosterone levels are measured, we take the blood and it's measured, the total testosterone may be normal, but that may be because of the effect of this. And yes, if Dr. Wirman agree, mitotane can definitely increase these levels of sex hormone binding globulin. But if that's the case, what would be your recommendation? It's kind of like going back a little bit so that way patients and caregivers understand about that concept and when would be an indication for replacement, if that's the case.
I don't think we have any data, but I think when we treat other men with hypogonadism, obviously there are some specific cancer drugs that definitely cause hypogonadism, which is low testosterone with signs and symptoms. I think you're pointing out that the testosterone, because of the SHBG, it circulates the free hormone with all these molecules. It may look pretty good, but it's low. But again, all our treatment guidelines for testosterone are not based on free testosterone, and most of the direct assays are worthless. So you would have to get a free testosterone by dialysis, and then you could, I guess, argue to give a little bit of testosterone. But if your testosterone's already 500, it would make me pretty nervous. So I look for other causes of why they don't feel bad or why they feel bad and try to look at those. And, is it depression, as we just heard about, anxiety, PTSD about what they've been through, or some med interaction, to look for that.
Right. Thank you for that explanation. Another question is, are there any dietary recommendations to follow while taking mitotane? Any, for example, antioxidants, if they're beneficial or not? In addition to any other food, are there any specific dietary recommendations or any supplements that needs to be avoided while on mitotane? If you can, it was a long.
Again, I personally think that anyone has to be careful about supplements and over the counter or online. And here in Colorado, we have a lot of abuse of a lot of pro-hormones and to make, this higher testosterone levels, DHEA, androstenedione and stuff. And we really don't know, either with the chemotherapy or with the mitotane, how they may or may not affect it. Is a multivitamin good? Yes. Is a vitamin D level, or check that and adjust it accordingly? Is eating healthy as much as you can good? Yes. But adding lots of other things, I personally don't know. And we can see what our next speaker will say related to his impression on whether it makes any difference, and your opinion. But because I just tell people not to overdo it. And we definitely watch the vitamin D and we watch their bones because of the steroids they're taking, et cetera, and their lipids, et cetera.
Yeah. Great, thank you. There's another question here, like if you touched, on that in your presentation as well, but if the patient is still experiencing fatigue after increasing hydrocortisone, what other options would you recommend, and how to prevent, what are the measurements that you recommend also to prevent adrenal crisis in a patient taking mitotin?
Again, my experience is that in the discussions I've had with people, and when they come to see us, most of the time, the trigger of adrenal insufficiency or the severe fatigue is related to the fact that who's ever taking care of them doesn't understand that mitotain metabolizes the steroids more frequently. And if you're going to use hydrocortisone, you're going to have to use it pretty frequently. And then that means food with it, and you're nauseated, et cetera. And the same thing with prednisone, occasionally we have to go up on the dose, but it usually doesn't help the fatigue. If they're mineralocorticoid deficient and they need Florinef, fludrocortisone, then that can help. It has a tiny bit of glucocorticoid in it. But I'm looking for other things. In Colorado, we have a high incidence of obstructive sleep apnea. So in everybody, not necessarily patients with ACC, so want to make sure that's not it. Are they anemic from the chemotherapy? And looking at that. So I think you look at everything else and then you try to be detective and sort things out. My experience that fatigue is usually not glucocorticoid deficiency unless they're using the old physiologic doses, and they really should be using more frequent doses.
That's great. Thank you so much again. I'm just going to ask a couple more questions. I know we're running a little bit of time, but I think this question is important as well. And that will be a question for Dr. Lockridge, and it's about, I know you mentioned this during your presentations, but if there is anything more that you will recommend, any other tools that you would recommend for caregivers during the cancer during the cancer journey of their loved ones, and help them cope as well.
Thank you for that. I often tell caregivers to do many of the same things that patients do. Caregivers also experience a great amount of stress, depression, anxiety, guilt, worry. I mean, they go through a number of emotions throughout the journey as well. And so frequently, I think there's a concern about whether or not they're taking care of themselves. And that tends to be either put to the background. And we frequently say, you need to reach out. The same things, have some social support, but also my biggest recommendation for caregivers and patients alike is really to tell your provider, get connected some way. They may not know, but they will know someone in the system who can reach out and say, oh, I know of a support group in this area. I know of another person that I can connect you with. I know of a therapist who specializes in working with caregivers. And so the best advice I can give is really ask the question and say, I need help. And it's as simple as that. It doesn't have to be dramatic either. It really can be just, I need help and I don't really know where to go, so I'm coming to you, and then put the responsibility back on the providing team and they will run with it. They really will.
That's great. Thank you so much, Dr. Lockridge. I know that we are at the time of the hour for the next session, but I think one question for Dr. Wyman, and this will be the last one, because I got a text about that. It was about your thoughts about the mitotin milkshake, and in terms of so
when we got into this field area, because of our multi-D clinic and everything, and seeing patients and trying to figure out going from the patient to the bench and back, we went to the international adrenal meetings, which were in Michigan, and Gary Hammer's team, their nurses use a milkshake. So they get the chocolate milk, they crush up the pills and put it in that. It's fat, right? So anything that's fat. And they're proponents of that. Some people like milk and can crush it up in chocolate milk and do that, or strawberry milk. We always say peanut butter, yogurt. We have some patients that get Whole Foods flaxseed oil. There's not been a controlled study, but they seem to get therapeutic faster with a tablespoon of flaxseed oil in there. So everybody has their little, the art of mitotain versus, and I'll be interesting to hear the Europeans' opinion about those kind of things. They're probably not as experimental in getting better absorption than US centers are.
I'll definitely going to ask that question to Dr. Torsala after his talk. But with
Yeah.
that said, thank you so much, Dr. Warman, Dr. Weirman, Dr. Lockridge, for wonderful presentations. There is still, I believe, a couple of questions in the chat, if that could be answered. And thank you again for your time. We're running a few minutes behind, but let's just give you like a 3 to 5 minutes just to stretch your leg, and we will continue with our last session of this meeting. Thank you. Okay. Now to our last session of this meeting. I have to say it has been a wonderful meeting. I definitely has been learning a lot too for all of our experts today. And I would like to now introduce the next speaker. It is my true pleasure and honor to introduce Dr. Massimo Terzolo. He's a full professor of internal medicine at University of Turin. He's a clinical and translational researcher with a focus on pituitary and adrenal disorders, and with a clinical expertise in adrenocortical carcinoma. He has led various advances in how we manage now adrenocortical carcinoma, and he has been an active member and written guidelines, European guidelines for adrenocortical carcinoma as well. And with that, Dr. Terzolo, the floor is yours. A pleasure to have you here today.
Many thanks, Jaidi, for the very nice introduction. I hope that you see my slide.
I see your slides. Oh, okay. Now I can see in presentation mode. Thank you.
Okay. So I'm very grateful to the patient organization for inviting me. It's really a pleasure and an honor to be here in the evening for me and in afternoon for you to discuss with you what impact does mitoten therapy have on patients with low-risk ACC. These are my disclosure, and this is the agenda of my presentation. I will briefly allude to the prognostication, since this topic was already covered by Alfredo Berruti, and then what was the concept behind the Adjuvo trial, that is the first prospective randomized trial on adjuvant mitoten therapy, and then the impact of the results of this trial on practice. In the guidelines on the management of adrenocortical cancer endorsed by the European Society of Endocrinology and also from ENSAT, an acronym that means European Network for the Study of Adrenal Tumor, some years ago we stated that at diagnosis, these are the prognostic factors that should be assessed. And I will briefly touch each of these apart from patient general condition, because it's obvious that poor patient conditions are a bad prognostic factor, because the patient could not be fit enough to sustain surgery or other types of treatment. Concerning stage, it has been already said by Alfredo, we use the ENSAT staging system, and you see what this means. So stage 1 and 2 are tumors confined to the adrenal, and these are obviously the best situation. Then we have a stage 3, which is a tumor with a local spread, and then stage 4 with distant metastasis, and obviously the prognosis is becoming worse as the stage progresses. And the stage is calculated with imaging and also with surgical results. Resection status, this is mainly derived from pathological analysis, and we have R0, the best condition, where there is no tumor left. Then we have R1, when there is a microscopically tumor residual, and then we have R2, where the residual is macroscopic, and sometimes the surgeon itself can say that there is a tumor left. And then we have Rx, when margins are not assessed or reported. And another important prognostic factor, again, this is done by the pathologist, is the Ki-67 immunolabeling or immunostaining. Ki-67 is a nuclear protein and a marker of cellular proliferation. So the more the Ki-67, the more proliferating and possibly more aggressive is the tumor. And you can see in the panel A, this is a tumor with a low Ki-67, 10%, and you see a few nuclei, a few spots in brown. This is high Ki-67, and you see more spots. And this is even higher, very, very high Ki-67, and you see a lot of brown spots. And this staining has replaced, at least in Europe, the mitotic count that gives the same information, but it is possibly less reliable and more difficult to assess. And then we have endocrine function, and this is our experience. You see that about half of the patient had clinical signs of endocrine excess, in most cases over cortisol excess, sometimes alone, and in most cases cortisol plus androgen. These are adult cases, so virilization alone is much less frequent than in childhood, in pediatric age. And the fact that cortisol excess is bad for the patient is the last acquisition, and also the most controversial, because there are data showing that this is not actually true. So this is still not sure, and by sure is not so strong factor like the previous one, stage or resection status and Ki-67. And these prognostic factors are helpful to try to understand what is the risk of recurrence, but taken overall, taking all the patients after surgery altogether is regretfully quite high. In our experience, about 60% of patients do have a recurrence, and you see that again, regretfully, in two-thirds of the recurrence, these are in distant site or in multiple sites. The timeline of the recurrence, these are more frequent in the first 2 years after surgery. Then from the 3rd to the 5th year, there are still a number, but they are decreasing for the 3rd to the 5th year. And after 5 years, we have very few recurrences. So in 2007, we published in the New England Journal of Medicine a retrospective study demonstrating that treatment with mitoten was associated with a benefit in survival. However, the study was retrospective, so it should not be considered as a conclusive evidence of the effectiveness of mitoten. And so we, and when I say we, it's myself, Alfredo Berruti, Dr. Berruti, and Dr. Fachstadt from Germany. We decided that it was time to try to do a randomized controlled study, because in the hierarchy of evidence, randomized controlled study are on top. And the idea was to randomize patients between mitoten and surveillance alone. But since we have got data that mitoten was beneficial, even if with a retrospective study, we could not dismiss this information, and we didn't consider ethical to randomize all patients to treatment or no treatment. And we tried to focus on the patient at low risk of recurrence. At that time, we are in 2008. We didn't have the information that we have now. But anyway, preliminary data from the German ACC registry seem to show that actually a category of good prognosis do exist, and this was characterized by R0, low-grade tumor, and local spread of disease. And so we designed the ADUO study, where the patient should fulfill all these criteria, so stage 1 to 3. We had a lot of discussion if we should really include stage 3, which actually is not so low risk. And in fact, we call it this category of patient at low to intermediate risk, but at the end we included because otherwise we thought that the number of patients should be too low. And so stage 1 to 3, R0, microscopically free resection, and Ki-67 less or equal to 10%. The patient with this characteristic should be randomized between 2 years of adjuvant mitoten treatment or observation without any treatment. The primary endpoint was recurrence-free survival with a sample size of 200 patients. Recruitment was difficult, and the Ki-67 less or equal 10% was the bottleneck of the recruitment. Because we didn't know that before the study, After complete surgery, okay, we have some 20% of patients who don't fulfill the criteria of complete resection, but even in between the patient with an R0 resection, only about 1/3 of these have a Ki-67 or 10% or less. So the first information of the study is that the category of low-risk patients are a minority, while most of the patients fall in the category of high risk. And this is the flowchart of the study. We had a high number of refusal to randomization, and we can then discuss this. But we didn't discharge this patient, but actually this patient were followed up in a parallel observational study when they managed as in the interventional study. But the only difference is that the decision between treatment and no treatment was not given at random, but was the result of a decision between the patient and the physician. And we had 95 patients in this observational non-randomized study and 91 in the interventional trial, 45 randomized to Mitoten and 46 randomized to surveillance only. And these are the results of the study. And first of all, you see a good survival, completely different from the average survival of the patient when we are taking all together. You see that at 5 years, we have an average recurrence-free survival of about 80% and an overall survival of about 90%. You see some benefit of the patient who are treated with Mitoten, even possibly more in terms of overall survival, but the difference was not statistically significant. But we have to underline that we didn't get to the predefined sample size. And so if we want to sum up the results, the first important point is the survival of this subset of patients is good and definitively much better than what we see in a patient with a high-risk tumor. Benefit of Mitoten was not significant, but cannot be definitively ruled out because we have a smaller sample size than planned. So this is not truly a negative study. But despite that, the clinical consideration is that adjuvant Mitoten is not routinely needed because also without any treatment, this patient have a 5-year recurrence-free survival of 80%. And the study showed that even in reference center, Mitoten therapy is not easy to do because even if low-dose Mitoten was used, a low-dose Mitoten approach, as it was alluded before, was used in most centers, but we had 90% of the patients who had to discontinue Mitoten for side effect, only 60% reached the target Mitoten levels. An important result of the study is that this confirms in a prospective way that SCC is not a uniform disease. And this was already possible to envisage from the retrospective data. This is our previous study, and you see that we have a patient who have a very rapid recurrence in 1 year, 1 year and a half, and then we have patients not recurring at all. In that study, in this retrospective study, we included all patients following surgery. And so for the first time, the ADUVO trial show that it's possible to capture this heterogeneity with a simple prognostication scheme based on stage, resection status, and Ki-67. And these factors can be done all over the world and not only in research settings. And we hope that in the future, biochemical or metabolic or genetic markers may further improve prediction. So what are the implications for the patient management? Okay, this is the first step toward personalized adjuvant treatment, because with this data, we can spare a subset of patients from a toxic treatment. But please don't generalize this result to all patients with ACC. I heard that many patients, after having seen the results of the study, stopped the imatotan treatment, and this is a very bad thing to do, because these results are applied to a minority, to about 25–30% of patients with ACC, and not to all patients. So don't stop mitotan, but consult your physician before doing that, because this, I mean, this is not a study that should be generalized to all patients. So what is my practice, the practice in our center after the publication of the ADUVO study? We recommend adjuvant mitotan in all patients who have Rx or R1 resection independently of all other the prognostic factor, or they have, if the tumor have a Ki67 more than 10% independently or other prognostic factor, or stage 4, because even, it was alluded before, even stage 4 patient, if they have a few metastatic sites with an aggressive surgery, can be rendered disease-free. Stage 3 is difficult because stage 3 is heterogeneous. Could be stage 3 because there is only one positive lymph node, or there are many, or there could be a venous thrombus. So I will discuss individually stage 3 for adjuvant mitotan, even if Ki67 is 10%. It is true that the stage 3 patients were included in the adjuvant, in the ADUVO trial, but we had very few of these patients. So I guess that stage 3 still merit a case by case discussion. I use a low dose starting regimen, so I fully agree with what was said before. It is more important that the patients stay on treatment than not the levels. I use adjuvant treatment for 2 years in most patients. We can eventually discuss this. And aiming at the stable mitotan level more than 10 milligrams per liter. Then again, we can discuss this, because you say that I'm not saying 14. And what is really important is a close follow-up. We should sustain the patient with all the technology that we have. I mean, phone call, WhatsApp, Facebook, video call, but we cannot leave the patient alone with the disease, with the side effect of mitotan, or leave the general practitioner to manage this side effect, because he don't have the expertise. If we see a patient now, and when we see a patient after 6 months, in between, the patient will stop mitotan almost in 100% of cases. And so as a last slide, this is a proposed flow chart. So after complete resection, low risk is a bit more restrictive than the ADUVO criteria. So only stage 1 and 2 and not 3, R0 and Ki67 less or equal 10%. All of these categories should be present. And if this is true, we can say active surveillance. This flowchart was published in 2022, so before the publication of ADUVO, but after ADUVO, we can say active surveillance. What is standard risk? And we have already discussed this. It could be adjuvant mitotan in many patients. And then there is also, in our opinion, a category of very high risk, and in this patient, eventually also chemotherapy can be used with mitotan as an adjuvant measure. And there is actually a study ongoing trying to test this, if this addition is useful, and this is the ADUVO 2 study. So having said that, I thank you for your attention. I'm ready to take your questions.
Oh, thank you so much, Dr. Terzolo. I appreciate it. Very wonderful presentation. I know there is a few questions in the chat as well regarding some of the questions that you also mentioned in your presentation, but we're going to now welcome Dr. Capdevila, and then at the end, we're going to have our Q&A session. And now it is my pleasure to introduce Dr. Jaime Catavilla. He is a senior medical oncologist at Vall d'Hebron University Hospital in Barcelona, Spain. He's a senior clinician and as well as a translational researcher. He has done multiple early drug development studies for neuroendocrine tumors and endocrine cancers. I have to say on a personal note, I admire Dr. Capdevila so much. I admire his energy. I don't know, he sleeps, he works so hard. He has so many studies. He really making a difference as well to understand and having therapies for neuroendocrine tumors as well as endocrine cancers. So I really appreciate you being here. It's a pleasure and an honor for you to be here, and the floor is yours.
Thank you, Yadira, and the love and admiration is mutual here. So thank you for inviting me and to give the opportunity for a medical oncologist that deals with, as you said, neuroendocrine, endocrine cancers, but also gastrointestinal tumors that sometimes give us a different view how to take advantage of some drugs that may be useful for rare cancers like adrenocortical carcinoma. And I will share my screen. I hope that you are seeing my slides. Yes, fantastic. So thank you again, and apologies if I'm going to too many details on data numbers, PFS, overall response rate, and these things that it seems that oncologists may not give a talk if we cannot talk about hazard ratios and waterfall plots. But this is, as Massimo said before, the reality. So we need to generate good data to learn how to apply the best strategies to improve outcomes. So these are my disclosures. And this is the outline. So I will review quickly the current standard of care. And then I will start with the problem that we have after the first line. So if we have more options with chemotherapy, what we may expect of targeted agents, all tumors use immunotherapy, why not in adrenocortical carcinoma, and what we may expect for the near future. So the standard of care. So before going to chemotherapy, we all know that mitotain is there to treat, as you said before, as you have learned before, for adjuvant therapy, but also for advanced stage disease. We use mitotain and other drugs to control hormone-related syndromes, but we know that mitotain can have an anti-tumoral effect by itself. It's not huge, but we can see some responses. Here in this nice table presented by Eric Bodin a couple of years ago at ESMO, you can see the summary of the different, mainly retrospective analysis and few small prospective studies that tested mitotain with objective of tumor growth control. We can see responses between 10 and 30%, and this is a dangerous number, as you will see during my talk. This 10, 15, 20% partial responses sometimes have an impact on progression-free survival and overall survival, but others not. And probably responses are not only the endpoint that we need to look for this special disease that sometimes is or always difficult to treat. Here you can see this summary, so some responses, as I said, between 10 and 30%, and it has an impact in guidelines, and these are the last ESMO guidelines. And here you can see that mitotain is recommended with local therapies or even alone in some particular cases. And which are these particular cases? So those patients with a more indolent disease, better prognosis, less tumor burden, where the responses are not needed at the beginning. And we need also to keep in mind that these responses may take some time to be seen on the scans. So we need to continue therapy some months, sometimes to see responses. And these responses may be related, or sure are related, with the mitotain levels in blood that sometimes are quite challenging. Moving to chemotherapy, the most famous study, the FIRMAC trial, demonstrated that a polychemotherapy plus mitotain is better than a monotherapy plus mitotain in advanced adrenocortical carcinoma. So this is the pivotal phase 3 study that stated that cisplatin, etoposide, and doxorubicin plus mitotain is the standard of care for the vast majority of patients in first-line therapy. And the study demonstrated a benefit in progression-free survival and a trend in also in overall survival. So this is the way that we should demonstrate things in oncology, in medicine in general, in oncology in particular. But as you will see during the rest of my talk, this is not an easy task to do. And studies like this one with this phase 3 study are not frequently seen in ACC. Responses are showed here, around 20% partial responses. Again, as I said before, these between 10 and 20% responses sometimes may have an impact in survivals and others not. So this is the reason that we need to demonstrate that in a prospective way in a randomized study. And we also need to deal with toxicity. As you well know, sometimes the hormone-related syndromes and the baseline conditions are not the best to support all chemotherapy at the same time. So we need sometimes to adapt this chemotherapy to that particular patient. So toxicity is there, but it's for chemotherapy itself, it's not something strange for oncologists because we use these schedules in other tumor types. But here we need to add mitotain toxicity that sometimes is difficult to manage, mainly for those oncologists that are not used to treat endocrine cancers and to deal with hormone-related syndromes. This is why this multidisciplinary approach is always mandatory. So this is what the papers show, but this is the reality that we may expect. So I could say yes and no. Here you can see a nice report of one of the best centers in the world to treat adrenocortical carcinoma. Italian friends, and here we have Massimo in the background, but the Brescia experience, it's a nice paper. Not only it's showing the different patient characteristics that we may deal with the first-line therapy with this polychemotherapy plus mitotain, but also showing that if you see here the median progression-free survival and overall survivals, it seems that they are longer than the phase 3 study that I showed you before. But in this particular experience, so the real experts in Brescia, they rescue some patients that have a nice response with chemotherapy, with surgery, and this has an impact in survival. So removing the tumor burden has a clear impact in survival in all endocrine cancers, and adrenocortical carcinoma is not different. So if you look at those patients that continued therapy without surgery, we have median PFS, median progression-free survivals, and median overall survivals pretty similar to the phase 3 study. So yes, this is what we may expect in those patients that cannot be operated after a nice response, but we should keep in mind that in some cases we may remove some of part of the disease, or even sometimes all the disease that the patient has, and then we have a clear impact in survival. And this is another experience from a US team that also reflects the options for systemic therapies. So if we only keep in first-line therapy, the polychemotherapy combination plus mitotain, and we cannot do anything else, it's impossible to have a clear long impact in outcomes. So what we need here is different lines. And I will speak a little bit in the next part of my talk about the different treatment options after first line. But here you can see that, for instance, in this particular case, when in 2007 they started the phase 1 unit, so new drugs came to the hospital, the patients started to have more systemic treatment options, not only in first line, but also in second, third, even fourth line. And then it has a clear impact in survival rates later on. So we need systemic treatment options to try to change the outcome of this disease. That being said, which are the other chemotherapy options for ACC? So here the evidence is quite poor because we don't have clear and good prospective, even randomized phase 2 studies, but even less phase 3 studies. We have different treatment options that I will summarize quickly now. One option is to do streptozotocine plus mitotain. This was the control arm in the Firma active study. In first line, we can see 9% partial responses, but some of these patients, you can see here, 84 patients that coming from the first line started to receive streptozotocine plus mitotain. And here we can see the impact of this streptozotocine in second line, around the same number of responses, this 8-10% responses with short progression-free survival, but that this is added to the progression-free survival getting the first line. So this is the only way to increase the final overall survival. With an advantage here, because we use only one chemotherapy drug here, so the toxicity profile is better than the combination of the triplet of chemotherapy. So this is an option based on the crossover of the phase 3 study that positioned the first-line therapy in ACC. If we want to move from that and use different chemo combinations, the evidence here is also quite poor, but we have some signal of activity. Here you can see, in the left part of this of the slide, a prospective phase 2 study with 28 patients, heavily pretreated, as you can see. The vast majority of patients received more than 2 lines of therapy. Overall response rate, again, 7%. Progression-free survival around 5 months. So this means that the first line, the second line, and then 5 additional months in third line. In the right part of the slide, you can see a retrospective analysis with more number of patients included here in this retrospective analysis that mimics a little bit what we can see in the phase 2 study. Responses slightly over around 5%, and progression-free survival around 3 months. So this is what we may expect in third line with gemcitabine and capecitabine, that this is also a well-known chemo combination that we can use in different tumor types, and why not here when the first and the second line are not working anymore. And there's also some evidence with temozolomide. This is also a well-known chemotherapy for endocrine or oncologists that treat neuroendocrine cancers, usually in combination with capecitabine. Again, in a small study, 28 patients, but some responses. Here you can see around 20% partial responses, progression-free survivals around 3-4 months. This is not a huge number, but again, as I'm saying, this is added to the prior progression-free survival. So this is, as I said, the only way to increase and to improve outcomes. And look here, the vast majority of patients included were in third line or more. So this is the evidence that we have with chemotherapy, and this is not huge, but we have options. And this means that we need to try these options when the conditions allow to do that. What happens about targeted agents? And here the things are slightly more complicated because we know the TCGA from the genomic analysis of ACC since some years ago. We have different mutations in driver genes that are not only a few of them. We have at least 8 or 9 main driver genes that may have mutations in ACC, involving 3 main pathways. You probably know the insulin-like growth factor pathway that is usually overexpressed in the vast majority of adrenocortical carcinomas, and in 1/3 we may see an involvement of the p53 pathway, and in the other third, the Wnt beta-catenin. But this is not only molecular alterations. It's not only genomics, what is important in oncology and in ACC. We have other molecular alterations or characteristics that may have an impact in survival. And in this recent publication, this nice publication, we can see that the combination of not only the molecular, the genomic analysis, but also methylation, the release of hormones, the immune infiltration, the expression of the insulin-like growth factor. So with these characteristics, the authors here may define 3 different prognostic molecular subgroups. And this is something that we should know. It's not easy because we cannot do these profiles of molecular analysis in all patients, but when we include our patients in a prospective study without knowing the baseline prognostic factors, then we may get wrong conclusions at the end. That being said, we have tried 2 main targeted agents in ACC, the multikinase inhibitors like sunitinib, that they have an anti-angiogenic effect with other additional effects targeting different receptors, and mainly different studies targeting the insulin-like growth factor. And here we have a phase 3 study led by the classical experts here. We have Massimo here, but no, Martin, Alfredo, Eric, no, the well-known experts in the world of ACC were involved in this phase 3 study. I think that many hopes were put in this phase 3 study because we know the target is overexpressed in ACC, and we had some phase 2 study with some responses. And you can see here the responses, and this is the small molecule that it's able to inhibit the receptor of insulin-like growth factor, and responses are there, but this has not impact in the final survival. So as I said at the beginning, it's not only a matter of responses, these responses may have an impact in the final outcomes. This may happen with other multikinase inhibitors, with other targeted agents. Maybe yes, or maybe not. We will need to see with larger studies, but we have better drugs that we tested some years ago. So cabozantinib is a better compound than sunitinib. It's much more potent with other targets that may revert initial resistances. And this phase 2 study was reported a couple of years ago at ESMO meeting. Some responses were seen here, but with a progression-free survival of 7 months and with an overall survival of almost 2 years. So this is only due to the effect of the drug, probably not, but maybe we have a longer effect of these compounds that may impact final outcomes. Or maybe it's only a matter of prognosis and patient selection. This is why we need a larger randomized study to demonstrate that. But at least something is there. With targeted agents, and what about immunotherapy? Here you can see on a small table with quick summary, the vast majority of the studies that tested immunotherapy, these immune checkpoint inhibitors in ACC, were part of a multi-cohort or a phase 1 study or an expansion cohort. Few of these studies were only focused on ACC, with experts behind the design of these studies in ACC. So the prognostication, the factors that may impact in the final outcome were not always well balanced. But here we can see responses again around 10% with short progression-free survival. A priori, immunotherapy is a good therapy for ACC, so we may say no. This is not the best scenario for the current immunotherapy, that we know today. So we know that we have a clear immunosuppressive microenvironment in ACC with the beta-catenin and p53 activation. We have this clear immunosuppressive microenvironment. We have low expression of the PD-L1, that is the target of these drugs, and even for the cortical excess production or because of the replacement, the vast majority of patients with ACC have high levels of steroids, and we know that steroids have a clear immunosuppressive effect. But we have seen responses with immunotherapy. Why? Maybe we have different explanations here. The first is that ACC, in some cases, are related with Lynch syndrome, 3, 4, 5% of cases, and Lynch syndrome is defined by the microsatellite instability. Microsatellite instability means a high mutational tumor burden, so high number of new antigens that may be a predictive factor of response of immunotherapy. But it's not only Lynch syndrome. We can see also MSI high, this microsatellite instability in patients without a Lynch syndrome. And not only with that, we have also other patients with tumors with high mutational tumor burden without MSI high or without a Lynch syndrome. We can see here, for instance, a poly mutation that produces a lot of different mutations that may be predicted for response of immunotherapy. So what we have here, you have here only one example. This is a phase 2 study with pembrolizumab. Responses, you can see here around 20%, but in the waterfall plot, you can see with different colors those patients with tumors with mismatch repair deficiency, the MSI high, and we can see responses not only in those that are MSI high. So as I said before, we have other predictive biomarkers of response to immunotherapy, not only MSI high. And even the progression-free survival is, again, very short. We have a long tail. This is what we look in immunotherapy trials. Long-term, those patients that get some responses, these responses may last a lot of time, and they may have an impact in the final outcome. With this rationale, we did a phase 2 study, multi-cohort, including adrenocortical carcinoma in our national working group. And 2-3 hours ago, my friend Enrique Grande had an oral presentation at ASCO GI. So this is hot coming from ASCO GI. The updated results of this phase 2 study combining cabozantinib and atezolizumab, anti-PD-L1. So maybe we could be better than the therapies alone that I showed you before. So the study had different cohorts, and what it has been presented today is the adrenocortical cohort. And the results are not what we expect at the beginning. 24 patients and responses around 10%, but the curves of PFS and overall survival are pretty similar to those that I showed you before with immunotherapy and even for cabozantinib. So the impact here is for cabozantinib, for immunotherapy, or maybe both, because here cabozantinib was given in a lower dose, so less toxicity and maybe the same efficacy. So I think that this is an approach to be explored a little bit more. And we have also done other studies with immunotherapy, and this study is called the Spencer study that we did in Europe. And it's a different concept. So what we tried here is a vaccine with neoantigens of the adrenal gland. So we included patients with ACC, but also with pheochromocytoma and paraganglioma. Here you can see the cohort of patients treated with ACC with two different cohorts, first line and pretreated. And the study combined this vaccine with these neoantigens of the adrenal gland with an anti-PD-1, nivolumab. Responses were around, again, 9% with a short progression-free survival, with some responses or stabilization that lasted some time. But again, here, I don't know if the impact on the evolution of these patients were because of the nivolumab efficacy or because of the combination. Sincerely expected a little bit more efficacy, but this is a different concept that we should continue explore. And what we may expect for the near future. So this picture, I did this picture yesterday. It's quite disappointing, as you can see. These are the ongoing trials that allow patients with ACC worldwide that are active for recruitment. Clinicaltrials.gov, it's not that minute updated, but this is the poor reality in the world. In the US, you have a slightly better scenario, but look what we have in Europe. We need to change that. And these 5 studies in Europe include the 2 prior ones that I showed you, the Spencer with the vaccine and the cabozantinib atezolizumab that Enrique presented today at ASCO GI. So this is ridiculous. So we need to improve that. And we have rationale to improve that. This is something that we are working on, and we can discuss that, Massimo, later on, but how to reduce the effect of corticoids and to reduce the immunosuppressive effect of this hormone to facilitate the activity of immunotherapy. This study is active, but not for recruitment in the US. I don't know results, but I'm not sure if this is enough, combining anti-PD-1 plus a drug that blocks the cortisol production. But this is a nice approach to explore a little bit more. And why not radiopharmaceuticals? Radiopharmaceuticals are fashion in oncology, and probably it's not the most important drug in oncology, but it's maybe the second one. For endocrine cancers, for sure, is the most important one. We have some case series with iodine and analogs of somatostatin receptors, but it makes more sense to target those receptors that are more specific of ACC. And this melanocortin 2 receptor that is overexpressed in adrenocortical carcinomas, there's a study ongoing doing both diagnosis and potential therapy targeting this receptor with a radiopharmaceutical. And why not targeting insulin-like growth factor receptor? So this is not a receptor that is exclusive for the cancer. We have this receptor in other cells in the body. So in this particular study, the approach is very interesting. So they're giving the cold drug with the radioactive agent to saturate the receptors of the body, and then they apply the hot one with the radioactive action to try to kill the cancer. So at least we have a couple of studies with radiopharmaceuticals that may have some light in the future. And why not ADCs? And you can review this nice video from Yadira that is available in YouTube. She's explaining here this phase 1 study with an antibody drug conjugate. This is a drug that targets a receptor with the antibody and carries a chemotherapy that is delivered in the place of the tumor, targeting this receptor, the DLK1, that is overexpressed in some endocrine cancers, particularly in those that are coming from the adrenal gland. So the best of the luck for you and your collaborators, Yadira. If we can get an antibody drug conjugate for ACC, this is the most fashion drug in oncology today and for the next 5 to 10 years. So these are my take-home messages. So we always say that adrenocortical carcinoma is a challenging disease to treat. We know that, but this is not an excuse. We need to have clear objectives in mind. We need to control hormone release. We need to improve baseline symptoms to then apply chemotherapies in the better way to have the better outcomes. And we need to share experiences. This is a complex and rare cancer. So those that have more experience need to talk with others that we have less experience to learn all together. We had some efficacy in immunotherapy in some particular patients. We need to look to them, to find them. A molecular analysis should be mandatory in all patients with ACC, and then try to select those that may get more benefit with immunotherapy. And we need to convince the pharmaceutical industry that this is a niche. And it means that there's nothing approved, particularly except mitotain for ACC. So if we can demonstrate a drug that works in ACC, probably the regulation of this drug will be quite quickly everywhere in the world. And this could be an opportunity for the patients, for the drug, for that particular drug, for the company, and for all together. And of course, international collaboration is mandatory. And this is why we are here today. And thank you again for your attention. And this is my final slide. So we need to learn much more, but we are here for doing that. Thank you.
Great. Thank you. Thank you so much. What a tour de force, Dr. Capdevila. That has been amazing and definitely a different perspective, not just of what we have, but also the need. So I really appreciate it. And thank you for giving a shout out to our study. And yes, this has been a long effort of 6 years. So we're happy to finally see here, and we're looking for collaborators as well. But thank you for that. So I'm going to ask a question to Dr. Capdevila first, and you have Ms. Ana Ramos. A great presentation, and really admire your work, as well as Ms. Rosa Maria Salcuni. I'm so sorry. Ms. Celia Dominguez as well. So send the greetings and thank you so much for giving us a presentation. But one question by Ms. Ana Ramos is about if you could give some explanation about therapies with CAR T, and what are your thoughts about that?
Oof, CAR-T. CAR-T in hematology works. In solid tumors, we need to wait a little bit. It's a complex scenario today to implement CAR-T cells in solid tumors. So the phase 1 programs are quite complex. I'm not sure. For hematological malignancies, they are there. But for solid tumors with heterogeneity, with the rapid evolution of the disease, with the time that we need to prepare the CAR-T cells, I'm not sure. I'm not sure.
There is so much that we still need to learn, right? And yes, we don't think that's something that I know there has been some studies about that, but so far not right time. I agree, and there's still so much that we need to learn whether this is something that it can be helpful in adrenocortical carcinoma. Not so much we have seen in other solid tumors like prostate cancer, breast cancer, and so forth. But yes, we're still learning about that. I agree.
Yeah,
And
this allows, at least this allows to characterize very good the tumors and maybe to find different targets with other drugs that are more quick to be applied, no? And this is the only way to move forward. So if we know perfectly, and we characterize all tumors, and the CAR-T cell process allows that, maybe I don't know, in any of the different ADCs, why not, or radiopharmaceuticals that are much more easy to be applied.
Yeah. And one follow-up question for Dr. Capdevila, and then I'll ask questions to Dr. Solo. But another question from Ms. Tina Ruben. If when a patient gets immunotherapy, pembrolizumab, do you stop mitotaine during the immunotherapy treatment?
For sure, after a good response. For those that last, these 3, 4, 5 months on therapy, that are those that are getting benefit, probably mitotaine is not doing anything else there. At the beginning, usually not. No, we all want to reduce the cortisol impact in the patient, in the environment, in whatever. But it's difficult to be maintained after having an initial response because the status improves, the hormone usually is reduced, and then mitotaine is not doing anything. There's only toxicity.
I just want to say that we have in our preclinical models, in our animal models and in our cells, we have intriguing data that suggests that mitotaine changes the tumor microenvironment and actually makes the tumor more active and responsive to the immunotherapy. So we have a significant cohort of patients who've been through the EDP and stayed on the mitotaine. And then as long as the mitotaine was near therapeutic and then were given immunotherapy, they have had long remissions. And so I think we don't know. I think it's tendency for oncologists to stop mitotaine at any time because they don't feel comfortable with it. And similar, we have a couple of patients with the same issue with the Cabo trials that are being done at MD Anderson, where they're stopping the mitotaine. And if you look at their data, the people who previously had mitotaine and might have still had mitotaine levels that were therapeutic had less toxicity with the Cabo and did just as well. So I think we're not exactly sure, both with TKIs and immunotherapy, when or if you should really stop mitotaine, and we don't.
I fully agree. So at the beginning, it's impossible to stop anything because we don't know how the things will go on. But it's very difficult when you have a nice response and that is lasting on time. I'm not sure if we need to maintain everything.
We have several cases where the mitotaine was stopped and the disease recurred, and then we put them back on.
We also have cases vice versa here.
Yeah, that's right.
And I don't know if there are Spanish speakers here, but we have one of our famous patient advocacies that she's doing that, and she stopped mitotaine when she had a nice response, and the last couple of years under response. So I don't know. We don't know neither in the other solid tumors if we need to maintain combinations, even if we need to maintain immunotherapy long term.
Yeah. Really dependent on the molecular drivers.
Exactly, and how the tumor evolves. And this is something that we don't know. We are not doing no sequential biopsies but it's difficult, no? But
Yeah. I don't see Dr. Tersolo. Oh, he's coming. Yes, he's coming back. I'm sorry. Dr. Tersolo, hey, hi.
I lost the connection, so.
Okay, great. Thank you. Thank you. One question for you, Dr. Tersolo. Could you please elaborate more about the levels of mitotin? There is a question here from Mrs. Catherine Lamy about an article that came about the myth of mitotin. And what are your thoughts about that? And are you rigorous to trying to keep mitotin to what we call it therapeutic levels of 14 to 20? And what are your thoughts about that?
Well, the 14 level is one of the magic numbers that we have in medicine. To be honest, this level was arbitrarily, born, and then we have only the retrospective data included mine. So, it's I guess pretty sure that if you go at 14 or even higher, you have more chance to respond. But this does not imply that if you have 13, 12, 11, you will not respond. So, and I have seen in my practice also responses with lower levels. So I'm not so rigorous as in the past to push to 14. And in fact, you have seen in my slide that I said 10. Okay, 10 is also empiric. We are now working and hopefully we will have some support for this threshold of 10. But particularly in an adjuvant setting, when you don't have a tumor, I guess that the quality of life is the first thing to preserve. So I am happy if the patient may have 10, and by sure I don't stop mitotin because the patient doesn't reach 14. Yes, it's sure that if the patient doesn't go up to 5, it remains 3 to 5, probably this is useless. But when this happens, it's because the patient is not compliant because of side effect or of our problem. But many patients can stay in the range around 10, and I'm quite happy, at least in an adjuvant setting.
Great, thank you. And another question is about the duration of mitotin. There is a question about stage 3 ACC and recommended adjuvant therapy after surgery. So what is your recommendations about the duration of mitotin? I think there's a lot of controversy, 3 years, 5 years. So yeah.
Okay. Again, we don't have solid data. We did a retrospective study, but it's very difficult in retrospective study because, if a tumor recurs after a few times, it is probably the biology of the tumor and not the treatment that, implies the response. But anyway, at least for low-risk tumor, it seems that 2 years is enough. And also 2 years is the period with the higher rate of recurrence. So it's also logical to cover this period. In my practice, for stage 3, for very high-risk tumor, if the treatment is well tolerated, because if it's not well tolerated, I stop after 2 years. But if rather well tolerated, I try to do 3-4 years. But in the past, we used to go for 5 years or even longer. But now we don't do that, also because many patients are young women. They may want to have a baby, and if they are continue to take mitotin, they couldn't have. And then after, when you stop mitotin in the body remains for years, at least for many months. And so, now we are shortening the period of adjuvant. I will say 2-3 years. But again, we don't have solid data. This is expert, if you call that, opinion or personal opinion.
Right. Thank you so much for that. A question for Dr. Capdevila, and I would like to mention, there is some patients, caregivers, Hispanohablantes, so speak Spanish. So thank you so much. And that means that the efforts of ACC Connections making this a global effort for patients and caregivers. So thank you for being here. And thank you for all of the patients that come from all over the world and are still listening to this meeting. So we appreciate really from the bottom of our heart. And a question for Dr. Capdevila is about the duration of immunotherapy. So there is a comment here that a patient has been on immunotherapy in combination with lenvatinib and has been with good response and has been on that for 1.5 years. So what is the recommendation? How long would you recommend a patient that has response with these therapies? How long would you recommend continuing this treatment?
The answer is that if the drug and the combination and treatment works, don't touch anything. Because this is hard to see. And then when you see that, if the toxicity allows, do not stop. We have a lot of experience with melanoma, for instance, with immunotherapy, and we have last many years to decide to stop therapies when we see complete responses. We are far in ACC compared to melanoma. So don't touch anything. So we can use immunotherapy for years without problems. Probably the toxicity of lenvatinib is more challenging than the immunotherapy itself. But maybe low doses and together with immunotherapy may allow long-term benefits. So don't touch anything till it works and it's well tolerated. I don't know if we will have this answer. Never. At least if we don't have a complete response. If we have a radiological complete response and then we can see that complete response at least for a couple of years, then maybe the disease is cured with immunotherapy. But if not, if you see disease, don't touch anything.
Okay. Thank you for that question, the answer. And there is another question here also for Dr. Capdevila, and then I'll ask another question to Dr. Trisolo. But for Dr. Capdevila is about alternative treatments. I think you did mention the current treatment, standard of care. You mentioned about streptozotocin. Streptozotocin, unfortunately, is no longer available in the US. Maybe available in certain parts in Europe, but not in the United States. But then what other options would you recommend? And you mentioned that, and your presentation was really nice, and you mentioned all the possible treatment options, but maybe the question will be like, after the standard chemotherapy, what options would you recommend as the next line of therapy? And also, what do you think is exciting for you in the future, or in terms of treatments for ACC? Hopefully Ms. Ramos, I hope I addressed that question. But yes, Dr. Capdevila, what do you think?
Yeah, this is something that you can sequence chemotherapies. I showed you platinum etoposide, and then you have gemcitabine, then you have alkylants like temozolomide. You can in Europe we can use streptozotocin in many countries. You have many drugs to combine, and then you may have these 3, 4, even 5 lines. I should include these alternative options much earlier, not at the end of this systemic therapy. So we need to start to test new options from the very beginning. First line, it's sometimes difficult, but as soon as we need to test new treatment options. Chemotherapies are always there, and we can rescue chemotherapies from the back, to give more systemic options. But sometimes we are not. So you saw the picture of clinical trials ongoing in Europe. It's ridiculous. Massimo, we need to change that. we were near to get that a few months ago with the European proposal, but we failed. But it's ridiculous. And the phase 1 units less and less allow, let's say, all tumors or all comers. usually the phase 1 studies need some molecular alteration to guide the therapy. And then we lose opportunities for those tumors that do not have clear driver alterations. ACC is an example, but we leave that in all endocrine cancers, except maybe thyroid cancer that has some genomic alterations. The others have nothing. And then the patients cannot participate in many phase 1 studies. So we cannot try new drugs and new compounds. These new compounds, of course, I like ADCs because it's something that you may create. So if you identify a target, you may you may create a new ADC. And the other thing is how this may be applied in humans, because the problem is that sometimes the target is shared by the tumor and other tissues. And these drugs are very potent, and then sometimes the toxicity is a limitation. But ADCs and with the same rational radiopharmaceuticals are probably the two main hopes for the near future in endocrine cancers and in ACC.
Yeah, thank you for that question. And just one question for Dr. Trisolo. What is the utility of 11-deoxycortisol levels as a tumor marker? That has been asked a few times.
I mean, adrenocortical cancer is not efficient, is not an efficient machine to produce steroid. And I mean, we may have adenomas, benign adrenocortical tumor of 2 centimeter and half producing overt Cushing. Usually, an adrenocortical cancer is much bigger because the cells are less differentiated and they have a loss of enzymatic defect, and so they produce a lot of precursor, and then in top also cortisol, but usually precursor are much more present, much more higher than cortisol. The problem is that currently the lab in clinics don't measure so well this precursor, but if we have gas mass spectrometry and we can measure 11-deoxycortisol, this is good as a marker to differentiate between adenomas and carcinoma. And maybe you have an indeterminate tumor at CT, not so big, and so 11-deoxycortisol could be useful. And could be, if it is elevated before surgery, it could be followed up as a marker to see if it's increased. It could be a signal of recurrence. But having said that, I have seen a lot of functioning tumor that recur as non-functioning. So I still trust more the imaging, but not the hormones. And this should look strange, said by an endocrinologist. But anyway, I'm not saying that the endocrine measurements are not good for the follow-up. Possibly, if you can have the panel, the steroid profile in urine, in some center, I know that Mayo in US is doing that. This could be particularly helpful because they test a lot of these precursors that are sometimes elevated when cortisol is normal.
Great, thank you. And I promise last question, because I think this is important for patients globally. And that will be for Dr. Capdevila, Dr. Solo. And I promise is my last question, how a patient can access to clinical trials in the UK and Europe. Any update on how patients can contact, how can get access to clinical trial, any tools and information for patients in other part of the world besides the United States to have access to clinical trials? And Dr. Capdevila or Dr.
In Europe, no, all Europe and now and also UK now, even it's not part of politically from Europe, but it's of course Europe. At least to the best of my knowledge, Massimo, there's nothing like a network through all Europe for patients and physicians to know the trials. So my recommendation is to touch the different working groups in the different countries. So we know, for instance, what we have in Spain, and we have a national working group that works, except for the president, that is not a very good guy, but the others of the group are amazing people that try to get the best for our patients. It's true that now it's as I said before, not ridiculous that we don't have any kind of study for ACC patients, but in a short past, we had at least 3-4 options on active clinical trials for ACC patients. So we were quite happy to have these 3-4 active trials ongoing, and we will have them again. So my recommendation is to touch the different national networks. You work very well and the referral centers in Italy, are well defined. Also in France, not in Spain, that it's not regulated, but we have the working group and also the patient advocacy group that may contact directly to all of us.
Right.
Yeah.
Dr. Solo, anything else?
No, I agree. What is true is that we have very few options, and is still, even if Europe is a sort of super nation, it's still difficult to travel from one nation to the other and have treatment in another nation. So this remains a barrier. So we have a lot of work to do to improve that.
I agree. Well, I have to say thank you so much. Thank you to all our patients and caregivers attending to this meeting. Thank you to our wonderful, wonderful experts today that dedicated their side or day to be with you all. I'm really, really, I'm so honored and grateful for the opportunity also to be with you and moderate the sessions today. And with that, I want to pass the podium to the ACC Connections team. Thank you.
First of all, as Dr. Del Rivero said, we want to thank all of you specialists who gave up your Saturday. You've given us so much valuable information that will go on. We want to thank all of our participants and all of our Facebook members, because we wouldn't be here without any of you. And we want to send a special thank you to Hope Law, who was excellent in promoting the conference. She wasn't able to be here today, but she did a fantastic job of promoting the conference, and it was great that she did that so that we didn't have to. Now I'm going to turn it over to Jolene Aria, who is also in ACC Connections, and she has a couple of things to say, and I will stop talking.
Echoing on Kathleen, I'd like to thank everybody for joining us today, especially thank the doctors again, like Kathleen said, for taking their Saturday, their weekend time to spend with us and share such great information with our patients. You guys are what make our group so special. You are engaging, you share personal information, personal stories. You are what keeps ACC Connections going, and you are what makes it great. I just want to drive home the fact that this conference and the conference we had last year, it's so important to see a true ACC expert. And when I say true ACC expert, it's probably not your local doctor. Even though you might love your local doctor, they more than likely are not an expert. There are not a lot of experts in the world. And
I said I was going to shut up, but I'm not, because I could talk for an hour about experts.
Yeah.
I love Dr. Del Rivero. I love her. I have great respect. She has done wonderful things for the community. She did great things for my husband. I would not want her replacing my hip if I needed one.
Right.
I would not want her to treat me for breast cancer. Could she? Yes. Do I trust her to do that? Yes. Are there doctors that are better suited? Yes. You need to find a doctor that is suited to treat the cancer that you have. You don't go to a breast cancer doctor if you have lymphoma. Why go to a local oncologist if you have ACC? Yep. Now I'll shut up.
It's okay. That was a good point. And another reason why I drive home the fact of seeing a specialist is when I was first diagnosed, we didn't even know there were specialists. I wasn't on Facebook yet. And so we just went to local doctors. I had my surgery performed by a urologist who had cancer and trained doing oncology surgery. It was performed laparoscopic. Before that, my PCP had me get lung, liver, and adrenal biopsies, which, as we all know in the groups, adrenal biopsies are not recommended. It could spread the cancer. I did eventually, after I was diagnosed, several months afterwards, I did see an expert. But again, before I had adrenal cancer, I always trusted all of my doctors and whatever they said. But now I question everything. When you have a 1 in a million rare cancer, you have to treat it differently. Like Kathleen said, you wouldn't go, to one doctor for this cancer, or you wouldn't see an adrenal cancer expert for something, a thyroid issue or something. So just please, 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 if I could drive anything home to you guys today, and I harp it all the time in the groups. And I always, one of my first questions is, have you seen a true adrenal cancer expert? That typically is not your local doctor who you love. It's one of the few experts that we talk about in the groups. It's so important. It's so imperative that you see a true adrenal cancer expert to be involved in your care. Before I did consult with one, and before I had my surgery, my former oncologist, which please note former, he said he was 99.9% sure that my adrenal mass was benign. And clearly that was not the case. And that's probably why they did laparoscopic surgery. My mass grew from 5 centimeters to 8 centimeters within a few months. So in reality, I'm very fortunate to be here. I'm very lucky to be here because I have friends that were in the same situation as I was, and they are sadly no longer here. So this is why I will harp until the day I die that you must consult with a true adrenal cancer expert, such as one of the ones that were here today, Dr. Del Rivera, who is now my cancer expert. Just please don't get tired of us saying that, because we say it with love. So thank you guys for joining us, and I'll see you in the group.
Hi, everybody. My name is Pat Fleet, and a lot of you know me from the groups. I've been there from the start. I was diagnosed 10 years ago, and this is what having an expert on your team at the very beginning means for you. I've had 6 surgeries. I've lived through 6 surgeries. I'm 70 years old this year, and I am as strong as I was when I was 40 or 50. And I need to tell you that this is not a death sentence, but when you get a recurrence, it's a call to action, as some famous doctor told me. And it's just important. And so I just wanted to once more drive that home, how important it was. I got to see a specialist. I was referred to a specialist at the beginning, not at the end. So that's my story. And I just want to say a couple of thank yous to Emerald Cromwell and Shannon Icon. They're a very integral part of us, the ACC Connections group, but they are both not doing very well right now. And so I just wanted to send a shout out to them, because they'll be back and they'll be helping us again. And so I'm looking forward to that. And I want to say a special thank you to Greg. And Greg, you know who you are, but you were absolutely wonderful in helping us get this platform together. And so I appreciate that.